All right, so nutrition. We know that nutrition is important. If our patients don't have good nutrition, they're not going to be able to get better. So we're going to talk about different nutrients that our patients need and different ways that we can offer them nutrition. So the objectives for this lecture are that we will be able to identify the 6 classes of nutrients, explaining the significance of each one. We will be able to describe risk factors for poor nutritional status, describe how nutrition influences growth and development throughout the life cycle, discuss the components of a nutritional assessment, develop nursing diagnoses that correctly identify nutritional problems that may be treated by independent nursing interventions, describe nursing interventions that help patients achieve their nutritional goals, and lastly, identify nursing interventions to safely deliver enteral nutrition. So the exemplars we're going to talk about are nutrition, the basic diets, feeding, and then enteral feedings. And you guys know that's what your skill this week is on tube feedings. Whoops. All right, so there are 6 classes of nutrients. Nutrients are the biochemical substances that our body uses for development, for growth, to participate in certain activities, to be able to reproduce, to maintain a healthy lifestyle, and then of course to be able to recover from an injury or an illness. These nutrients provide energy for our cellular metabolism. They help maintain our tissue and they repair our tissue. They help with organ function, growth and development, and then physical activity. So nutrients that supply energy are our carbohydrates, our proteins, and our lipids. Water is the most basic of all of our nutrients, and it's extremely crucial for all body fluid and cellular functions. And nutrients that regulate body processes are going to be your vitamins, your minerals, and your water. So that's all 6 classes: water, carbohydrates, proteins, fats, fatty acids, vitamins, and minerals. So the rule of thumb for determining an ideal body weight. So your literature says that for adult females, 100 pounds and a height of 5'5", that you should add an additional 5 pounds for each additional inch over 5 feet, and that would be the ideal body weight. And then for adult males, the average weight of 106 pounds and a height of 5 feet. For each additional inch over 5 feet, you should add 6 pounds. So this is the method for calculating caloric intake. I am not going to ask you to do this, but you can read this at your own leisure, and this is how you figure out a patient's or yours the basal metabolic rate. It's a pretty simple process, but I'm not going to ask you to do it. So if you guys want to read over that you can. Your body mass index. So body mass index, or your BMI, I'm sure you guys have heard of a BMI, is just a ration of your weight in kilograms to your height. It is considered to be a reliable indicator of total body fat that you're storing. To calculate this, you take your height and your weight to calculate your BMI and what they determine to be an ideal body weight. So you would determine the client's weight in kilograms, and in meters, you would multiply the client's height by itself to determine the M value, divide that weight in kilograms by the height value from step 2. This result is the client's BMI. So I'm not going to ask you to calculate a BMI. We all have access to that on the internet. We can just type it in and then plug in the numbers and it gives us the ratio, but it is good if you know how to do it. What I want you guys to be concerned about is what the guidelines of the BMI are. So a BMI below 18.5 is considered underweight. A BMI of 18.5 to 24.9 is considered a healthy weight. A BMI of 30 or greater is considered obese. And then a BMI of 40 or greater is extreme obesity. So a BMI also provides an estimation of a risk for diseases such as heart failure, heart disease, diabetes, hypertension, high cholesterol. You guys need to understand that if a patient is below 18.5, that you need to do some education with them to find out where their nutrition status is lacking and how can you educate them to make better choices so that they have a healthier BMI. And then also when you get to above 30 and 40, recognizing those opportunities to educate your patient about living a healthier lifestyle so that they don't have to worry about developing those chronic illnesses. So what are some factors that affect our basal metabolic rate? So our basal metabolism is nothing other than the energy required to carry out our involuntary activities of the body at rest. So it's what our body uses, the energy it needs just to function, to breathe, to metabolize our food, to excrete urine. And it's the energy needed to sustain the metabolic activities of all your cells and tissues. So males tend to have a higher BMR due to their larger muscle mass. It's not the same with every man. There are certainly women who are built bigger than men, but men tend to have the higher BMI. BMR. The BMR is about 1 calorie per kilogram of body weight per hour for men, and it's about 0.9 calories per kilogram of body weight for women. So there are certain factors that increase our basal metabolic rate. So growth when we're growing as adolescents, infections, fevers, emotional tension, when you are subject to extreme environmental temperatures, and then elevated levels of certain hormones. So this is an important slide. I want you guys to remember this. Factors that decrease our basal metabolic rate would be aging, prolonged fasting, and then sleep.
Ms. Davis, can you let Martha Lynn in? She says she's trying to get in.
Yes, thank you. Okay, so if you know that if you have a patient who is has a fever or a patient that has some type of serious infection, you're going to think right away that these patients are going to have an increased metabolic rate and they're going to require nutritional interventions. Okay, I want you guys to think about that. So this is just a, there's a lot of risk associated with being obese. There's been multiple studies over the years that say that everything from heart disease to breast cancer, you're at risk for if you carry a certain percentage of fat around your abdomen, around your waist. So measuring patients' BMI and measuring their weight circumference is extremely important for being able to determine what population of patients you're caring for are going to be at risk for these diseases associated with obesity. So we want you to be able to know if you're in a primary care office, not so much in a hospital, but the outpatient setting where you would measure a patient's waist. So you can see there's the man here and then the woman and then the skeleton kind of just gives you an idea of where you would place that measurement tape if you were actually measuring the waist. All right, so carbohydrates. So carbohydrates are also known as sugars and starches. They provide our body with energy and fiber. Each gram produces 4 kcal. They provide glucose, which burns completely and efficiently with end products that we ultimately excrete from our body. Sources of carbohydrates include whole grain breads, baked potatoes. You can get them in brown rice, other plant foods. Organic compounds are composed of carbon, hydrogen, and oxygen. They do serve as the structural framework of your plants. Your lactose, your milk, is the only animal source. They are abundant and least expensive. They are the most abundant and least expensive source of calories in the world. And you can also classify them as simple or complex sugars. So carbohydrate intake is often correlated to a person's income. As an income increases, carbohydrate intake decreases, and then you see an increase in more of a protein instead of carbohydrate, because it's a more expensive form of energy. Carbohydrates should consist of about 45 to 65% of your total calories for adults, and we should be focusing on complex carbs such as whole grains. And these are all the things you're going to want to tell your patients. So you want them to have healthy carbs. So you want them to have vegetables, lots of fruits. Fruits you have to be a little bit careful with, especially with patients that have diabetes, because even though they're fruit, they're still sugar. And it is possible for them to intake too much of it, and it can affect their blood sugar numbers. So you have your whole grains, you have your seeds, your legumes, your nuts, your beans. These are all your healthy carbs that you would want to encourage your patient to take in. So 90% of our carbohydrates are ingested that we take in. They are converted to sugar for transport throughout the body. Once that happens, the cells oxidize that glucose to be able to give us energy, carbon dioxide, and water. And then we need about 50 to 100 grams of carbohydrates daily to be able to prevent ketoacidosis. So ketoacidosis is something that can cause people to be very sick. Non-diabetic, it happens to diabetics. It can also happen to people that don't have diabetes. So we call that non-diabetic ketoacidosis. It's a rare condition, which is caused usually by starvation. It's a lack of glucose in the body, which then forces the body into a state of ketogenesis, and then that ultimately is going to cause metabolic acidosis. You guys are going to learn a lot more about that next semester. You might see this happen to patients sometimes that are on, or friends or family members that are on low carb diets. This happens sometimes. And metabolic acidosis is just an acid accumulation in the body, but it can shut down organs, and it can cause people to be very sick. All right, so nutritional ketosis and diabetic ketoacidosis is completely different. Nutritional ketosis, or DKA, is completely different. So DKA, which is diabetic ketoacidosis, is very dangerous, and it can potentially be life-threatening. It occurs in patients that have type 1 diabetes who have not taken enough insulin. It can also happen to type 2 diabetes where they're left uncontrolled. So DKA develops when the ketone levels in the patient are approximately 10 times the level that you would see in the nutritional ketoacidosis. So everything's really, really out of whack. The high levels of ketones are very, very dangerous. They make the blood acidic, causes the patients to be very, very tired, lethargic. Some patients will be dizzy, they'll be nauseated, they're going to be extremely thirsty. As it progresses, you're going to notice they become very short of breath, and then eventually they can go into a coma, and then actually they can die if it's left untreated. So when patients decrease their dietary carbohydrate intake to around 20 to 50 grams a day, the body starts to adapt for that lack of carbohydrates by increasing its burning of fat. Therefore, the higher levels of ketones are produced in the liver and the blood ketones rise. And this places the body into a state known as nutritional ketosis. So the two of them are completely different. So how do we manage our carbohydrates in health promotion? We want to limit that added sugar in certain foods. If we want to avoid them because, sugar on the teeth can cause cavities. And then we want to increase our dietary fiber and our whole grains. All right, next is our protein. So proteins contribute to our growth. They maintain and repair our body tissues. Each gram of protein produces 4 kcals. Sources of complete proteins include beef, whole milk, poultry, certain vegetables. Proteins are required for the formation of all body structures, including our genes, our enzymes, our muscles, our bone matrix, our skin, and our blood. Dietary proteins can be labeled either complete, which is high quality, or incomplete, which is low quality, based on their amino acid composition. Complete proteins contain the sufficient amounts of proportions of all the essential amino acids that are necessary to support growth. And those are our animal proteins, such as eggs, dairy products, and meat. So those are complete proteins. They have everything that we need in them. Incomplete proteins are deficient in either one or more of those essential amino acids. And these are our plant proteins. So these are our grains, our legumes, and our vegetables. The body's protein tissues are in a constant state of flux. They're always changing. They're always being broken down and replaced. So if you remember back to biology, when our body is breaking things down, that's catabolism. And when it's being replaced, it's anabolism. Our protein intake should include 10 to 35% of our caloric intake for adults, and these should come from a variety of protein foods. Especially important for you guys to understand in hospital in your hospital patients, they're going to have poor wound healing. This is really important. I want you guys to know this. You need to make sure that when you're taking care of your patients in the hospital, and your patients want to order something, that you encourage them to order something that has a lot of protein in it, because if they're sick, they really need that protein for wound healing. That's an important slide. You guys are going to see that again. So how do we digest protein in the body? Well, obviously we take it in through our mouth. Digestion starts in our stomach. Then we have hydrochloric acid, which converts to pepsinogen, to the active enzyme pepsin. The small intestine is the principal site where all of our proteins begin the digestion process. And then we have enzymes that are located on the surface of the cells that line the small intestine to help complete that digestion process. So how do we absorb proteins? Well, we have those amino acids, and then there's a few dipeptides and some of those larger peptides that are absorbed through the mucosa of the small intestine to help absorb everything. And then everything gets metabolized through the liver. So the liver acts as what they call a clearinghouse. It's going to help retain those amino acids to make liver cells, non-essential amino acids, and plasma proteins, such as heparin, prothrombin, and albumin. So our albumin helps keep our blood volume up. Sometimes we give patients albumin if their circulating volume is very low, if their blood pressure is soft, and they have difficulty keeping their blood pressure up. And that prothrombin, we need that to help make our blood clot. It removes nitrogen from the amino acids. It converts proteins to fatty acids, which form triglycerides for storage in adipose tissue. Triglycerides are not good for us. And it helps to form urea from the nitrogenous waste of protein. So these are our top sources where we get protein from our veggies. So you have your spinach, which probably has the most amount of protein. Kale is next, followed by broccoli. Then you have cauliflower, mushrooms, parsley, cabbage, green peppers, cucumbers, and tomatoes. So these are all the things that you can recommend to your patient because they're going to get the most bang for their buck because they're so high in protein. And then, of course, you have your chicken and your beef, and then eggs. Fat. Our fats provide energy and vitamins. Fat should not be any more than 35% of our daily caloric intake. Each gram of fat produces 9 kcal. Sources include, these are good sources, olive oil, salmon, and egg yolks. It is composed of carbon, hydrogen, and oxygen. And then 95% of lipids in our diet are triglycerides. So they contain mixtures of fatty acids. So you have your saturated fats, which help raise your cholesterol levels. And then your unsaturated fats, which you want to incorporate these in your diet to help lower your cholesterol levels. Most of your fats from animals are saturated. Most vegetable fats are unsaturated. So this is why we want to educate our patients about having unsaturated fats and getting them through your vegetables so they can lower their risk of developing heart issues. Because cholesterol builds up in our vessels and causes blockages, which can make your patient have a heart attack. Oops. All right, so fat digestion occurs mainly in the small intestine. It is the most concentrated source of energy in our diets. There is no recommended daily allowance established, but recommendations say no more than 20 to 35% of your caloric intake per day should be fats. You should have healthy fats. They help you stay fuller longer. So your healthy fats are good. Trans fat is bad. It occurs when manufacturers that make food, what happens is they partially hydrogenate their liquid oils. The trans fat raises your serum cholesterol levels circulating in your blood. Lipids are what we call fats in our diet, and our triglycerides are mainly found in the form of fat in food. And it's the major storage form of fat in our body. And then just a little background, cholesterol is a fat-like substance that we only find in animal products. So my husband, I always like to share this. So months ago, my husband had to go on cholesterol medicine and he didn't want to take it. Did I tell you guys this story already? No, okay. If I ever start to tell you the same thing, interrupt me. He has like a significant cardiac history in his family. Grandfather, father before him, all died from a heart attack. His father had a heart attack at 42. So he's always been conscious of his diet, but the doctor told him he had high cholesterol and he didn't want to take the medicine that he wanted to give him Lipitor and he didn't want to take it. So we went back and forth for months and he refused to take the medicine. And I'm like, you're going to die. You're going to have a heart attack. You need to take the damn medicine. So he went to the doctor and the doctor said, you need to take it. There's no ifs, ands, or buts. You're going to have a heart attack if you don't. So he said, well, I want to change my diet. So he was like, okay, I'll give you 3 months to change your diet. When you come back to me, if it hasn't done, you need to take the medicine. So he decided to become a vegan. He went all out, not just a vegetarian, but a vegan. He doesn't have any animal products at all. No milk, no eggs, no nothing. So he's been a vegan for over a year now, but he did his first 3 months and then he went back to his doctor and his cholesterol was like below normal. No high cholesterol at all. So those animal products definitely are not good for us. He's still a vegan. I don't know how he does it because I got to have my dairy. I love my dairy. I could go without meat, but I definitely love my dairy. But so there's some good education for you if you want to talk to your patients about high cholesterol. All right, vitamins. So vitamins are necessary for metabolism. Organic compounds are needed by the body, but in very small amounts. Most of them are active in the form of what we call coenzymes. They are needed to metabolize carbohydrates, proteins, and fats. The fat-soluble vitamins are A, D, E, and K. And then the water-soluble vitamins are C and B. They're absorbed through the intestinal wall directly into our bloodstream. So vitamin A is good for visual acuity. It helps our skin, our mucous membranes. It helps promote our immune function so we can fight off infection. Vitamin D provides calcium and phosphorus metabolism, and it helps stimulate calcium absorption. Vitamin E is an antioxidant that protects vitamin A. It's good for our skin. Vitamin K helps the synthesis of certain proteins that are necessary in our components of blood clotting. If you have a well-balanced diet, you do not need to get these vitamins outside of the diet. So if your patients, this is an important slide, if your patients are talking to you about, well, I take this, and this every day, you can tell them if you incorporate these vitamins into your whole foods, through all the food chains, and you have a well-balanced diet, you will not have to get these vitamins from an outside source. Minerals. So minerals are complete essential biochemical reactions in the body. So these are our calcium, our potassium, our sodium, and our iron. They're organic elements found in all of our body fluids and our tissues. Some function to provide structures in the body. Others help to regulate certain body processes. Excessive soaking and cooking in water can cause the loss of minerals from certain foods. It's contained in the stomach after the remains of digestion. We have macro minerals, which include calcium, phosphorus, and magnesium. And then we have micro minerals, which are our iron, our zinc, magnesium, and our iodine. So there's all your vitamins. You can find this chart in your book. Just tells you where you can get these certain vitamins. So vitamin D, you can have some fish. It's found in margarine and eggs. Calcium, you're going to find that in produce like dairy, produce, and then milk. And then your B vitamins, so certain meats, cereals, and fish. Vitamin C, your oranges, your lemons. Vitamin A, also in eggs, liver, carrots, and fish. And then your iron, so those red meats, your spinach, and certain cereals. Because a lot of patients don't really, I don't even know these, honestly. I know the basics where I can get them in my diet because I'm pretty good with my diet, but I don't know every single one of these. So this is actually a good slide for you guys to keep, maybe take it to your clinical with you when you're talking to your patients about how they can improve their diet. You can use that as a reference. So water. Water is more vital to life than food because it provides the necessary medium for all of the chemical reactions in our body, and we don't store water in our body. Water is crucial for cell function. It replaces fluids that the body loses through perspiration. So when we're sweating, when we have a fever, or if we're exercising, through elimination, and then through respiration when we're breathing. It accounts for 50 to 60% of our adult total weight. 2/3 of our body water is contained within the cells. So if it's in the cell, it's intracellular fluid, ICF. And then the remainder of our water in our body is in extracellular fluid. So that is outside of the cell. So that's your plasma and your interstitial fluid. We're going to talk more about that next semester too. Water provides the fluid medium necessary for all the chemical reactions in the body, and it acts as a solvent that dissolves many solutes. It aids in digestion, absorption, circulation, and excretion. So if you have a solvent, that's going to be your liquid. Your solute is always what you're putting in there, what you're going to have disintegrate in the water. So what are some factors that affect nutrition? There's a lot. So religious and cultural practices absolutely guide the way a patient or a client will prepare their food and the choices that they make. Culture influences what they eat, if it's considered edible, how it's prepared, what combinations of food can be permitted to be cooked together, eaten together on the same plate together. There's always financial issues. Limited funds prevent some clients from buying foods that are higher in protein, vitamins, and minerals because they tend to be more expensive. Appetites decrease when patients are sick, depending on certain medications that they take can decrease their appetite. When patients are in pain, they don't have much of an appetite. If they're depressed, that affects their appetite. And then any unpleasant environmental stimuli can affect a patient's appetite. Negative experiences with certain foods or familiarity with foods will help to determine preferences. So we have something called a learned aversion. So in patients that have cancer, when they take chemo, we always tell them that while they're taking chemo that they should avoid their most favorite food. So for example, if your most favorite food is pizza or crab cakes, you shouldn't eat it while you're taking chemo because we know that there's a huge side effect with chemo, which is nausea and vomiting. So if you eat your favorite food and then you vomit, you can develop what's called a learned aversion. So I don't know if you've ever had food poisoning before. I have. I got deathly ill one time from Don Pablo's, and then I developed a learned aversion, and I never ever went to Don Pablo's again because I was terrified that I was going to get sick. So if you've ever had food poisoning and then you ate something that you cannot ever eat again, then we call that a learned aversion. You have environmental factors such as sedentary lifestyles, work schedules that can permit how good our nutrition, that can cause a problem with how much we eat and how good our nutrition is. If we're working all the time or if we're going to school like you guys are and working, we might not be eating like we should be. When we do eat, our food choices might not be that great. And then having access to less healthy foods contribute to obesity. Unfortunately, we live in a time where it's cheaper to go to McDonald's and Chick-fil-A than it is to prepare healthy meals. Medications can alter a person's taste and their appetite and can interfere with absorption of certain nutrients. And then age also affects our nutritional requirements. As patients get older, they tend to have less of an appetite, and foods taste different. So developmental considerations. Babies from birth to 1 year of age experience the most rapid period of growth. Their birth weight doubles in 4 to 6 months, and it triples by the time they are a year old. Their nutritional needs per unit of body weight are greater at this time than any other time in their life cycle because of the high energy requirements. So they will ideally have formula or breast milk. They will start eating solid food at 4 to 6 months of age. And then they say no cow's milk or honey for the first year due to allergies. Those toddlers, 12 months to 3 years old, and preschoolers 3 to 6 years old, they're starting to be able to feed themselves, or they can feed themselves. They're able to tell you certain foods that they like and certain foods that they don't like. They do have an increased need for protein from sources other than milk. So we would go back to that food scale that we had back here and look at those groups of foods where we can get the most protein. They have calcium and phosphorus are important because their bones are developing and growing, and they need that intake in calcium and phosphorus. Children in this group often experience inadequate intakes of fruits and vegetables and are excessive intake of sweetened fruit drinks, because we know kids, they can be no limit soldiers. And if they don't want to eat and you're tired of listening to them scream at the other, all day long, sometimes you'll just give them a bag of gummy bears because they're quiet. That's just what happens sometimes when you're a parent. All right. School-age children 6 to 12, they need supervision to consume adequate protein, which include vitamin C and A. They tend to eat foods that are high in carbohydrates, fats, and salt. They love that processed food. They have increasing energy patterns that need to be balanced with foods that have a very high nutritional value. So these kids are running around playing a lot of sports. They're involved in different activities. We need to make sure that we're balancing that energy need with good solid food. They have an uneven, individualized, sometimes erratic growth pattern. Kids develop and grow at different patterns. No two kids grow the same way. And the body accumulates reserves in preparation for upcoming adolescent growth spurts. So sometimes you'll see kids in these age groups that start to get a little bit of fat around their belly or in their face. And then once they hit that growth spurt and they go, that fat disappears because they basically grow into themselves. Then you have adolescents, 12 to 20 years old. This is a period of rapid physical, emotional, social, and sexual maturation. Metabolic demands are high and they require more energy. They need a lot of protein, a lot of calcium, iron, iodine, folic acid, and vitamin B needs. Increased water consumption is very, very important for this active group. They're very, very active. Children in this group tend to consume inadequate amounts of fruit, vegetables, whole grains, and dairy products. So something to watch out for with the kids. Young adults, 20 to 35 years old. And then our middle adults, 35 to 65. You're going to see a decline in the basal metabolic rate with each decade, and fewer calories are required. So you're going to notice that when you're 20 and 23, 25 years old, you can eat whatever you want, drink whatever you want, and you're never going to gain a pound. Well, once that basal metabolic rate starts to slow down, it's going to be a different story. You're really going to have to watch your intake. Calcium and iron are essential minerals for women. As women get older and they start to lose estrogen, that affects their bone health. And it's hard for women sometimes to get calcium and vitamin D through their diet. So we tell them to take calcium and iron. We want to have good oral health. This is extremely important because the plaque that you see on your teeth is the same plaque that can develop in your heart. So we want to make sure we're encouraging our patients in the hospital to brush their teeth and explain to them how important it is. Adults may become more aware of the preventative role of exercise. I can honestly attest to this. I feel like I never really exercised when I was younger just because I didn't have to. I could eat whatever I want. And then all of a sudden I got older and I had to start exercising. And now that I'm 50, no matter how much I diet, the fat doesn't budge. I actually have to work out. And it's important. Your heart's a muscle, our body we need to be able to work out. So that we can be healthy adults and healthier older adults. Weight gains result if adjustments in caloric intake are not made. So if you don't decrease the amount you're taking in, you're going to see that you have that weight gain. And then the pressures of work and family lead to a decline in physical activity and exercise. And I'm sure you guys can attest to that. So older adults over 65 years old, they have a slower metabolic rate, so now they require fewer calories. Our older population is very at risk for suffering from dehydration because our body has a mechanism that tells us when we're thirsty. So if we've done certain activity that makes us thirsty or we're just thirsty, we haven't had anything to drink in a couple hours, our body tells us. With older adults, they lose that sensation. They don't feel thirsty anymore. So they don't drink as much as they should, and then they end up dehydrated. Many older adults require carbohydrates that provide fiber and bulk to help enhance those gastrointestinal functions because the basal metabolic rate slows down. Everything in the older adult slows down, even our GI motility. So we have to find different ways to incorporate fiber and bulk to bulk that stool up so that they're not constipated. Because of the changes related to aging, their caloric needs of the bodies decrease. The needs for vitamins and minerals will, however, stay the same. So we still need to make sure they're getting those nutrients and minerals. And not only do the women need calcium supplementation, but the men also need supplementation. So risk factors for poor nutritional status. So developmental factors. So gender, men are different from women in their nutritional requirements due to the differences in our body composition and our reproductive function. Men tend to have larger muscle mass, which translates into a higher caloric and a protein requirement compared to women. A patient's state of health, fevers, if they're sick, is going to increase the need for more calories and water. Any kind of major surgery, if a patient's had a burn, if they were in an accident or any kind of an injury that resulted in a crush to any of the body parts, is going to increase the need for more calories. Hormonal changes have a profound effect on our body and the way that we use nutrients. A patient's mental health can also have an effect on their nutritional status. So if they're depressed, maybe they don't feel like eating. If they're not happy, they might not be taking care of themselves and they don't have much of an appetite. If they're confused, they might forget to eat, they might forget to drink, and then they lack that motivation to eat, which contributes to malnutrition. If they abuse alcohol, so alcohol can alter the way the body uses nutrients. There's a greater need for the B vitamin. The toxic effects of alcohol on the intestine, on the mucosa that lines the intestine, interferes with the body's ability to absorb nutrients. So this increases the efficiency of the absorption, which then decreases. So you will see in patients that come in for whatever reason, if they're coming in for alcohol withdrawal, you'll see that a lot, or if they just come in for something else and they have and they are an alcoholic, a lot of the times you're going to be giving them what we call banana bags. It's like a looks like a bag of normal saline, but it's all yellow. It comes in like a liter bag and it has every vitamin under the sun. And they need those vitamins to be given intravenously because they can no longer take them in and they can't absorb them because of the damage that they've done to that mucosa by drinking alcohol. Certain medications, so nutrient absorption can be altered by drugs. So there's some drugs that actually change the pH of the GI tract. There's some drugs that increase GI motility, and then some drugs will damage the intestinal mucosa, like we said, what happens with alcohol. And then some drugs bind with nutrients, which keep them from being able to be absorbed in the body. Because if it binds to them, then our cells can't take them in. And then we have megadoses of nutrient supplements. So some dietary supplements can have drug-like effects and they can interfere with food and medication. Because some nutrients compete against each other for absorption, an excess of one nutrient can lead to a deficiency in another because they're both competing for the same site, especially if one is absorbed preferentially. So eating disorder, this slide, I've seen this, I saw this slide in nursing school. I guess this has been circulating around forever. And it's hard to get this vision out of my mind because when you see people like this in their mind, they still think that they're fat, even though we don't see them. But I cared for a patient one time that looked similar to her, not as bad, but she would do laps on our floor every day because we were making her eat. She was waiting to get a bed at Shepherd Prep, but they didn't have any beds. So she was on our floor and we had to make sure that she ate. We had to do a calorie count. We had to count her food. We had to, sometimes we had people sit with her and watch her eat. Well, she was eating the food, but then she was so upset because she thought she was fat that she would start walking and walking and walking for hours on our unit because she wanted to burn it off. So it is very sad taking care of these patients. So patients with a BMI of less than 18.5, those are considered underweight. Anorexia nervosa is a significantly low body weight for their gender, their age, their developmental level, and their physical health. It is defined as a fear of being fat, Anorexia or a lack of appetite can be related to systemic and local diseases, on any number of psychosocial causes such as fear, anxiety, depression, pain, and then impaired ability to smell or taste can also cause anorexia, or it may occur secondary to drug therapy or medical treatment. So anorexia itself, we use that terminology all the time when we think of a patient that just doesn't have an appetite. Anorexia nervosa is when they have all these issues, that psychological and the nutritional issues going on, and then they have that BMI of less than 18.5. So then you have bulimia nervosa, which is a cycle of binge eating followed by purging. So they eat what they want because they need to have the food. And then as soon as they eat it, they go in and they vomit, or they use diuretics or laxatives. And they can also exercise and fast because they want to equal it out. They don't want to gain any weight, but they want to have the food. And then there's binge eating disorder. So this is repeated episodes of binge eating. They feel like they have a loss of control when they binge eat. So they can't help themselves. They go and they binge eat. After they binge eat, they feel really bad about themselves. They feel guilty. They're ashamed. Then they start to be depressed. Many times patients that have binge eating disorders are overweight or obese. So when you guys do nutritional assessments on your patient, you're going to make sure you're doing a thorough history, find out what their dietary preferences are, what their medical history is, what their socioeconomic situation is. Try and have them put together like just a normal day. What does a normal day in their diet look like? What do they have for breakfast, lunch, and dinner? You can probably gather from the meals that they have a little bit about their socioeconomic status. You want to make sure you're doing a thorough physical assessment. You're doing that anthropometric and clinical data. So taking those measurements of body fat and measuring that waist circumference, looking at their height and their weight. And then you're going to look at laboratory data. So you're going to pull labs that look at protein status, look at certain vitamins and minerals and certain trace elements in the body. So when you want to get information from them about what their diet looks like in a day, you can, like I said, have them do a 24-hour recall. So that's going to include their calorie counts, ask them to make a food diary and a food frequency record. Make sure that we are asking questions that are geared so that the patients will be able to give us good information about how they ate in the past and how they currently eat, so that we can really try and take a look at their food intake patterns. We want to ask them if their current intake differs from their usual intake. So if they are smaller now or thinner now than they were, or they weigh less, what's that from? Did they have intentional weight loss? Have they been trying to have a healthy lifestyle? Are they exercising? Find out who they usually eat meals with. Do they eat by themselves? Are they lonely? Do they live by themselves and they don't have anyone to eat with? How is their food normally prepared? Do they fry their food? Do they bake it? Do they broil it? That gives you some ideas about what their lifestyle, their eating lifestyle is like. We want to know any medical, social, or economic factors, as well as those cultural influences and psychological influences. We want to be able to really be able to evaluate their nutritional requirements. So we have to know their food choices. So that way we can better tailor their education plans. If you look in your book on page 1296, there's a mini nutritional assessment. You guys can look at that. Factors to assess for nutritional status. So we want to look at dietary data. So we're going to do that nutritional screening. We're going to assess their dietary intake through those food diaries and those caloric counts. We're going to look at medical and socioeconomic data. We talked about that anthropometric data. That's the measurements of the size and the proportion of that human body. And then that laboratory data we're going to look at that we talked about. So when we pull certain lab tests, we could look for hematocrit and hemoglobin. That would give us information about their iron levels. We could pull albumin as a lab. That would give us information about their protein status. If we wanted to know more about iron, you could look at ferritin. You could also look at transferrin along with the hematocrit and hemoglobin. You could also pull cholesterol levels. That's going to tell you about their current lifestyle of eating. We could look at their glucose and then their triglyceride level. So there's a lot of different labs that we can look at that can tell us, even if our patients aren't honest with us. So this is the My Food Plate. This is based on an initiative from the Dietary Guidelines for Americans. This was designed to help people make better food choices that will allow them to follow healthy eating from across their entire lifespan. It looks, they use a familiar image that most people will be able to understand because it's a place setting for a meal, and then it helps us look and determine the proportion of our grains, our protein, our vegetables and fruits and dairy that we should have on our plate. So you see the biggest portion here is vegetables, followed by grains, and then our proteins, and then our fruits, and then of course the serving of dairy. So this is just a sample of a nutritional label. If you are in the outpatient setting, probably if you work with an endocrine specialist or where patients that have diabetes work, you would be going over this nutrition label with them to explain to them how they should eat. So the nutrition label includes the serving size. It includes the calories per serving. So on this nutrition label, the serving size of whatever this food is a half of a cup. So in this entire container, there are 4 half a cup servings. For each half a cup serving, there's going to be 90 calories. 30 of those calories are going to, 30 of the 90 are going to come from fat. So the total fat here is 3 grams or 5% of the daily value. So remember we said a couple slides back, how much should we say our fat intake should be? I don't remember what we said. I felt like it was at least 20%, 15 to 20%, 20 to 25%. So there you go. If you're looking at percentages each day, you already have 5% right there with just a half a cup of whatever this is. We have our total carbohydrates broken down into grams and then also percentages. So some people measure calories, some people measure macronutrients. So they look at these grams, and then some people do the percentages. So it lists all of them right there, depending on what plan you're following. Talk about our dietary fiber intake. Our protein is listed there. What vitamins and minerals are listed in here. The nutrition label offers a lot of information. And then it also lists your daily value. So if you, the daily value is for people most of the time who eat 2,000 to 2,500 calories a day. So if you eat more or less, then you would want to change that a little bit. So that's the nutrition label. So nutrition interventions, what can we do for our patients? So we want to teach nutritional information, all the stuff that we just talked about. Once they tell you how they eat, if there's room for improvement, then you would recommend the things that we talked about: increasing protein, lowering that fat intake, limiting that fat intake to those healthier fats, making sure we're having just that limited amount of carbohydrates with our meals, showing them that My Plate is a good visual for when you're doing education with patients. We want to, if you're in the outpatient center, you're going to monitor that nutritional status. So if a patient comes in and they want to lose weight and they're not living a healthy lifestyle, you're not just going to set them up with education and then say, good luck, come back if you have any questions. You're going to want to make sure that you follow up with them. They should be coming back every 30 to 45 days at first to make sure that they're following and that they don't have any issues. Make sure that you can stimulate their appetite. So be sure that the food that they're getting looks attractive. So in the hospital, this is where we're kind of limited. Usually the food isn't good. Most patients complain about it. It's not seasoned to their liking. If they are on a heart healthy diet, most patients aren't following a heart healthy diet at home. And then when they come in and they have high blood pressure, we put them on a heart healthy diet and they don't have any salt. So that upsets them. You want to make sure that you can order for them. So I see a lot of older patients that can't order themselves because maybe they're too sick or they're weak or they don't have good dexterity with their hands. And the nurses or the techs have to order for them. And a lot of times what the nurses and techs do is they put them on what's called a house tray. So nobody has to order for them each day. Their meals just come, but they don't get to have a say in what they want. So sometimes they wind up getting food that they don't like. So here's a patient that's sick. We want them to have an adequate amount of all the important nutrients. We want them to have a lot of protein, but yet we're not ordering food for them. We're just letting dietary bring whatever they want. And if they don't like it, they're not eating. So they're not going to get better. So be the nurse that asks the patient what they want. Take the 4 minutes out of your day, 3 times a day, a total of 12 minutes. Ask your patient what they want and place the order for them if they cannot. If they get food that they want, they're going to feel better. They're going to get that good nutritional intake and they're going to be able to heal and go home. Make sure that we're controlling their pain. If maybe they were having stomach issues and they weren't able to eat, but now the doctor put them on a clear liquid diet. Give them some nausea medicine, some anti-nausea medicine before they're going to order their food. Touch base with them and say, Mr. Jones, here's your menu for a clear liquid diet. The doctor really wants you to try and keep some food down. How about you let me know when you're going to order? And after you order, I'll bring you some anti-nausea medicine, and that's going to help prevent you from getting nauseated. Be aware of those certain medications that are going to cause patients to have some kind of GI upset so that you can avoid that. You don't want to give that medicine when they're eating. And then try not to disturb mealtime. So eventually, patients, when they come in the hospital, they are sick, and sometimes they have to go for tests. They have to go for x-rays. They have to work with PT. But having them eat is also very, very important for them to get better. So if PT calls and says, hi, I want to work with your patient, Mrs. Jones, I'm going to come down now. It's perfectly okay for you to say, can you just give him 10 minutes? His food tray just came. I really want him to be able to finish eating. It's not unrealistic. You need to advocate for your patient. And then assist with eating. Some patients can't eat themselves or they're really weak and they just can't do it because they get exhausted. Sit by your patient's bedside, feed them their breakfast. Maybe you have to go to that patient a little bit later. Maybe they're going to get their breakfast around 10 or 10:30 after you pass your meds because you might not have a tech and you have to pass meds, but you can always heat their food up, go in and spend that time with them when you have a couple minutes and help them eat. Involve the client as much as possible, right? With eating, doing what they can. Maybe they can't completely feed themselves, but maybe they can hold a cup. You can feed them their food and they can take a drink. Engage in pleasant conversation. Patients tend to eat more when they're just sitting around and they're talking and they're not thinking about it. When you have patients who are visually impaired, make sure that you explain where things are located. You can always use the location of the clock as an example. So here you go, Mrs. Jones, here's your chicken and potatoes and carrots. Your chicken is at 12 o'clock, your carrots are at 3 o'clock, your mashed potatoes are at 6 o'clock. Make sure that you're doing good oral nutrition with your patients. This makes their food taste better. This makes them want to eat. And then make sure you're providing long-term nutritional support. Looking at your patients, realizing if it's been a couple days and they haven't eaten. So if you give them breakfast and they don't eat any of it, and then you say, okay, that's fine. Sometimes we don't feel like eating. And then at lunchtime, their lunch comes, you set it all up and they still haven't eaten. So now here's 2 meals that they haven't eaten. Then you probably want to talk to the doctor and say, look, we need to do a nutrition consult. She didn't eat her breakfast. She didn't eat her lunch. So just make sure that you're aware, because if your patients aren't eating, then you're going to want to make sure they're getting maybe some lactated ringers or some type of IV fluids to get them over that hump until they start having an appetite again. So we have, this is an important slide. You guys are going to see this again. We have different oral therapeutic diets. A clear liquid diet. So this is a diet that leaves, this includes all liquids that leave a very little residue. So these are clear, obviously. These can be your fruit juices, your gelatins, certain carbonated beverages, and chicken broth, and beef broth, and vegetable broth. So if the patients that you usually see on these diets, or when they are not tolerating other diets, sometimes it's the first diet that we give after they've had any kind of bowel surgery, or if they've had a lower endoscopy, any kind of major GI disorder. Usually it is the first post-operative diet that we give. They'll have an order that comes in the computer that says clear liquid diet, and then the nurse can advance as tolerated. So your patient would come back from knee surgery at 10 o'clock. They'd have that clear liquid diet by 12:30. They've tolerated it fine. They're not nauseated. They're not having diarrhea. They're not having any belly pains. And then you would advance their diet as you saw fit. Usually we would just go to a regular GI soft diet from there. A full liquid diet is anything that's on the clear liquid diet plus dairy products, all juices, and then you can have pureed vegetables. A pureed diet is clear and full liquids plus pureed meats, fruits, and scrambled eggs, which are really gross. They just kind of come like in a blob, or sometimes they're in like like they've been in some kind of a mold. They look terrible. You'll see these in patients that have swallowing difficulties. So if they've had a stroke, if they're on aspiration precautions, maybe when else? Oh, if they've had any kind of oral surgery, any kind of facial surgery, or any kind of chewing issues. Then you have mechanical soft diet. So this is your clear and full liquids plus diced or ground foods. This again would be your chewing or your swallowing difficulties, any kind of surgery on the head, the neck, the mouth. And then we have our soft, low residual diets. So those are foods that are low on fiber and easy to digest. So this is the diet that you would put your patient on post-operatively after they had their clear liquid diet. For breakfast, then you would give them this soft, low residual diet for lunch. And then if they didn't have any health issues, you could put them on a regular diet for dinner, or whatever their regular diet is. So our high fiber diets, those are diets that have those whole grains, those raw and dried foods. We use high fiber diets to help treat constipation. Patients that have irritable bowel syndrome or diverticulitis or losis also follow a high fiber diet. Low sodium, so this is no salt added or 1 to 2 grams of sodium. These are your patients with hypertension, heart failure, renal disease. Renal disease could be acute or it could be chronic, and then patients with liver disease. Low cholesterol. So this is considered no more than 300 milligrams a day of dietary cholesterol. So these are your patients who are at risk for having heart issues. So your hypertension patients, your heart failure patients, they're going to be on low cholesterol diets. Then you have your diabetic diet, which is a balanced intake of your proteins, your fats, and your carbohydrates. It is approximated at 1,800 calories a day. The patients that are going to stay on this diet are going to be your type 1 diabetes, your type 2 diabetes, your gestational diabetes. So that's patients that get that are pregnant, that have diabetes when they're pregnant, and then any patient that has an impaired glucose tolerance. So maybe you have a patient who doesn't have diabetes, but they have some issues going on, like a COVID patient. COVID patients are getting IV steroids if they're in the hospital, and then they're taking them when they go home for sometimes long periods of time. So patients that are on steroids have issues with maintaining a lower blood sugar. If their blood sugar is out of control. So they might want to temporarily go on a diet like this. Then you have your patients who have dysphagia. So they have issues swallowing. So they're going to be on pureed foods and thickened liquids, because if they're not on pureed foods, they can pocket it, they can choke on it. Thin liquids, they can aspirate on. And then you have your regular diet, which is no restrictions. Some patients require short-term nutritional support. So our short-term nutritional support is going to be, so if you have a patient, so people like us, I consider us to be healthy, well-nourished patients. If we had to go into a hospital and we had to be NPO, nothing by mouth, we could do this for a day or two. But anything after that, we could probably do it even up to 3 days. But after that, for an extended period of time, it starts to become a challenge. Then these patients require short-term nutritional support. So we want to start thinking, what kind of nutritional support are we going to give them? If it's going to be less than 4 weeks, then we would give them what we call a nasogastric tube. So this is a tube that we insert, nurses insert this, it goes through the nose, down the back of the throat, and it will end up in the stomach. So for less than 4 weeks, the nasogastric tube is the ideal route to go because it is temporary. The risk with an NG tube, there can be a risk of aspiration in the lungs. When we put in an NG tube, we have to confirm that the tube has been placed appropriately in the stomach. So the only way that we do that in the hospital, I told you that we teach you by the book, and then we're also going to tell you what happens in the real world so that you know. Hold on. I just let Raven in if she's asking. So in the real world, when we place an NG tube, we will place it once we get it into the nose. So how we measure it, we're going to talk about this weekend, but how we measure it is we take the end of the tube and we put it at the patient's nose, and then we hold it there, and then we pull it back to the ear, right? And then we hold it there, and then we bring it down to about the xiphoid process, and that's where we're going to stop measuring. We're going to get that mark on our tube. It usually has numbers on the tube, and say it's at the 50 or the 55. We'll say it's at 55. So then when we go to insert it into the patient's nose, we'll stop at that 55. We normally fold a piece of our surgical tape around that so that we know where we stopped at, so that any nurse that comes behind us will be able to gauge if that tape is moved further out. Then we're going to know that that NG tube has moved. And that happens all the time with patients. So once we put that tube in, we send our patient off to X-ray, and then we get an X-ray that says, yes, the tube is seated in the stomach. It's okay for you to use. If it's not, then we take it out and we put it back in, or we push it down further, whatever type of an adjustment needs to be done. We're going to teach you in clinical or in the lab that you will do a radiographic examination, but then you're also going to do a measurement of the pH. And then you're going to do a visual assessment of the aspiration that you pull back. We're going to teach you that you would pull back from the NG tube, or from the tube, you would squirt it into a little container. We'll go into all this weekend. It'll make more sense. And then you're going to measure the pH. We don't do that. I've never done that as a nurse. We don't do it. It's expensive. So we just don't do it anymore. So like I said, you're going to measure the tube and the length. We can use this to monitor carbon dioxide. So you're going to want to monitor carbon dioxide, because sometimes that nasogastric tube position can change, or it could dislodge, and it would detect the presence of carbon dioxide if the tube was positioned in the patient's airway. So that's why you would want to monitor their carbon dioxide. And then you're going to want to confirm that tube placement again, which is by the x-ray, or what I still do when I have a patient is I will listen. You can, you'll use a syringe and you can pull up like 30 cc's of air, and I put my stethoscope over top of the abdomen right where I would hear it, and I would push really fast and you can kind of hear like a swoosh of air. So I do that, and then you can always pull back and check the residual. And if you're getting stomach contents out when you pull back, then you're probably in the stomach. So we don't check once we say it's placed and it's confirmed via an x-ray, we don't ever do another x-ray unless for some reason we think that the tube has moved. So then when we talk about long-term nutritional support, so if it's going to be more than 4 weeks, we're going to want to do that enteral feeding. That's for long term. We're going to do an enterostomal tube, which is placed through, they create an opening in the stomach or into the jejunum. So you can have, if it goes into the stomach, it's a gastrostomy, which is a G tube, or if it's in the jejunum, it's a J tube. It's just a doctor preference where they put it. The G tube is the preferred route for patients who are comatose. We place the tube in the stomach. A surgeon does it, usually a gastroenterologist. And then the PEG tube hangs out. So you guys don't have a picture on there like I have. I don't know why you guys don't have this picture. Let me copy this and put it here for you guys to see. Okay. I don't know why you guys didn't have that. So this is what this is what the PEG tube looks like. It can be a J tube or a G tube. Even if it's a J tube, some people just call it a G tube. I feel like it's always just a G tube. So you can see how they go into the stomach right there. They go through the stomach, it goes through, it has this little piece on the end that keeps it from coming back through. Usually after this goes in to the patient, after they first put it in, you'll have some crusting that comes around it for like the first week or two. So you always want to, whether it's new or 25 years old, you always want to check the site every single day, every single shift. You want to make sure it's clean, dry, and intact. You want to make sure if there is any drainage, you're cleaning that up, because that drainage can sit on the skin and break the skin down. We do have these dressings right here that are cut down the middle. It's called a split gauze, and we just work it up underneath of that little part right here, and it kind of protects the patient's skin. So if there's a lot of drainage coming out, I would put one of those around the patient and then just change it as it's required. And then this is how we're going to hook them up to tube feeding through this end part right here, and then we will feed them according to the doctor's orders. So dietitians, who are dietitians? Well, they come and they do nutritional assessments on your patients, and they calculate the estimated calorie and protein requirements based upon the data that they get through that physical assessment. They determine nutrition diagnoses that define any nutritional problems that they find, what's causing those nutritional problems, and any signs and symptoms associated with those problems. They also may determine the appropriate malnutrition diagnosis, and they formulate nutrition interventions to help getting that patient back to a good nutritional status. So what kind of clinical data are we going to look at? We're going to look at physical signs and symptoms of malnutrition. These signs and symptoms don't usually appear until the conditions are advanced. It takes a while before we see them. Let's see, they don't appear until the condition is advanced. We want to look further and investigate whenever we see abnormal findings. We want to see what they're caused by. So if we have a patient that has high blood sugar and they don't normally have high blood sugar, well, then that's going to prompt us to start asking more questions. Do they have some kind of nutritional deficiency somewhere? If we have a patient who came in just because they had a knee replacement, but then we did their morning labs and their hematocrit and hemoglobin were off. Well, we might think, do they have a problem with iron? What is their dietary status look like? Maybe they're eating well, but they still have a nutritional deficit with iron. So maybe they need to take a supplement. So we just want to start recognizing issues and then understand that we have to think outside of the box and start correlating, those issues to what we see. We want to look at any barriers to eating. So if you're dealing with your stroke patients, do they have dysphagia? Are they at risk for aspiration? Do they have Parkinson's or dementia? So Parkinson's, people get very weak and they're also very, very, very shaky. You'll see that these patients, a lot of them really don't want to eat because it's frustrating to them because their hands are shaking so bad. And then you have patients with dementia and they just are confused and they forget to eat. Also look at dental issues. So did your patient come in and they don't have any teeth and they didn't bring their dentures with them? They're not going to be able to chew. You're going to want to contact their family members, see if they can bring those in. How weak or tired are they? Are they even having a hard time just finding enough energy to eat? So looking at all that important assessment information. Medication. So prescription medication and medication over the counter can have the potential to affect our nutritional status. The greatest risk for development of drug-induced nutritional deficiency are those who, on a regular basis, consume few calories and nutrients than they need. Those patients who have an increased nutrient requirement, including the infants, the adolescents, and those pregnant and lactating women. And then our elderly people, because of their changes in sense of smell and taste, sometimes they get GERD, because remember I told you everything slows down. So they do develop GERD because their stomach muscles aren't as tight, and then their food starts to come back up and then they feel like they always have indigestion. Looking at those dentures that they don't have or that maybe they don't fit, if they're starting to lose teeth or they have loose pain. And then of course our older adults are on a limited income sometimes, so do they have access to nutritional food? And then of course your patients that have chronic illnesses. And I didn't turn the slide, I don't think, did I? I did. Patients who take large numbers of drugs every day. So studies show that patients who take at least 5 or more, whether it's prescription, over the counter, any kind of combination or dietary supplements, that they tend to have issues with nutritional status. Patients who are on certain long-term drug therapy, patients that are self-medicating, substance abusers. So all your substance abusers, you'll see patients that come in that are addicted to prescription pain medicines, or maybe they're on heroin or cocaine. Their nutritional status is very, very poor. They go days and days and weeks without eating. I don't know how they survive sometimes, but their intake is terrible. Physical signs and symptoms that you're going to see. So their hair is going to be dull. It's going to be brittle and dry, might even fall out easily. You might notice swollen glands in the neck, dry, rough, or spotty skin, poor or delayed wound healing or sores. This is extremely important for your diabetic patients. They have a hard time healing as it is because of the diabetes. So then if their nutrition isn't good and they don't have good protein in their diet, they are at even more of a disadvantage. They may appear thin with lack of subcutaneous fat, or they can just be the complete opposite. Oh, this is malnutrition. So they might have a change in bowel habits, inflammation, bleeding gums, poor denture health, poor posture, muscle wasting, sometimes edema in those lower extremities, weakened hand grasp just because they're weak all over. They could be in a depressed mood. Nutritional status can cause abnormal heart rates, rhythms, and blood pressure issues, especially if you have problems with your potassium. You could develop an enlarged liver or spleen, a loss of balance and coordination, and then dry eyes. So what are some nursing diagnoses? I'm not going to read over all these, but you guys can take a look at these. You can find all these in your nursing diagnosis book. So diagnoses that we would want to consider. So we're going to look at patients that are at risk for aspiration. So these are your patients who have had a stroke. These are your patients who you think may be having a stroke. These are your patients who came into the emergency room and they're not alert and oriented. They're very, very fatigued. They're very groggy. They have a hard time keeping their eyes open. These are the patients that you would want to make NPO and put them as a risk for aspiration because they're not with it enough to be able to communicate with you. So they're definitely not with it enough to swallow medicine, swallow water, or any kind of liquid, and they're not with it enough to swallow food. Altered oral mucous membrane. So this would be just your patients who are maybe comatose in the ICU, very fatigued, they sleep a lot, that aren't getting good mouth care. These are your cancer patients that have chemo, altered dentition, patients that have impaired skin integrity, patients that are not compliant with their nutritional recommendations, if they have impaired swallowing, knowledge deficits, these patients who are in pain, and patients that are dealing with being nauseated. So age-related concerns with the elderly. So they have functional limitations. Aging itself will cause a progressive decline in their physical function. Major causes of functional limitations include the development of arthritis, an issue with your joints, makes it hard for them to walk depending on where the arthritis is. If it's in their hands, they have a hard time with their dexterity, being able to do things. So maybe they're going to have a hard time feeding themselves. Maybe they're just even going to have a hard time preparing their food. Osteoporosis, sarcopenia, which is loss of muscle mass related to aging. And then we have Alzheimer's, and then obesity. Age-related concerns for elderly, so social isolation. So sometimes maybe they're not married and they live alone. Maybe they've lost their spouse and they live alone. Maybe they have children who, live out of state and they don't get to see each other a lot. It's very easy for the elderly population to feel socially isolated, which in turn causes depression, and then it affects their nutrition because they're not eating. People don't like to eat alone. This is also a big risk factor for poor nutritional status. You want to make sure, so you can do something called Meals on Wheels, where if their patients can't get out and they can't get their foods, they will have 3 healthy food meals delivered to them every day. Sometimes they'll do it in 3-day increments. They come right to them, drop off all the food. It is based on your income. You want to make sure that you are modifying their diets as needed. So if they're diabetics, you want to make sure they're on their diabetic diet. If they have heart issues, make sure they're on low sodium diets. Make sure they're on renal diets if they have those kidney issues. And then you can make sure, you can try and recommend that if they have family that's involved, that maybe they do a weekly dinner during a certain time. They could take turns so that way their loved ones aren't eating alone. So some of the things that we see in long-term care. So,
Ms. Davis, I don't mean to interrupt, but can you show it, please?
yes, thank you. So there's a multitude of reasons why people go into long-term care. Multiple diseases, many different kinds of conditions cause people to have to go into long-term care. So long-term care is where a lot of people that don't have family members or have family members who can't take care of them, and these people can't take care of themselves anymore, this is where they go to live. So these are our nursing homes. They don't always have the best quality of life in long-term care, unfortunately. They suffer from weight loss. Then they lose weight. They lose weight because their nutritional status isn't good. Then they start to develop these bony prominences. They start getting the skin breakdown. It affects their quality of life. Their quality of life is not good. Ways that we can help prevent, we have a little bit more flexibility in long-term care. Their meals are prepared there, but their family members can come in and they can add things specifically to their diet. They can leave them snacks and food in their room. They can help them order the foods, because usually in long-term care, you order sometimes a week in advance. You'll get your menu and you'll circle what you want for your meals for all 3 days. You can have family come in and do that. You can encourage family members to come in and eat with them. They can come every day. They can come once a week, whatever they can do. Make sure that if they're having issues with their dentures, that we get their dentures fixed. So it's very common that we see a patient who may be 85, 86, 87 years old, mid 80s, sometimes even early 90s. They still live at home. They're still with it mentally. They're still driving, but then something crazy happens and they fall down. They have a fall. They break their hip. The patient breaks their hip. They wind up being hospitalized. They are in a lot of pain. They're not moving in bed as much as they should be. They develop pneumonia. The nurse never gives them an incentive spirometer, and then the patient can pass away. So once they get older, you'll see these things they're very, very common. You'll hear loved ones say, I don't understand. He was living at home. I don't understand what happened. All he did is break his hip. Why didn't he get better? Well, it's obvious to see with what I just talked about, how we kind of, by our lack of interventions, we kind of progress that patient towards ending up in long-term care or ultimately even dying because the patient wasn't moving. We didn't get him out of bed. We didn't make sure he had that incentive spirometer. We didn't do our part. And then we talk about this liberal diet approach. So for me, when I see a 90-year-old patient that comes in and they put him on a heart healthy diet, I just am like, really? Because he's 90 years old. Let the guy eat whatever he wants to eat. That's just how I feel about that. So if my patient asks me to get him something from the cafeteria or bring them something out of the nutrition room and it's not going, if they're not like on a fluid restriction or it's nothing major, I give it to them. And we want to encourage that with our older patients who are having nutritional issues. We want, because if they're eating something that they like, they're going to take more calories in. So this is just a repeat of what we said before with these oral diets. You can go to page 1305. Table 36.4 talks about those different modifications in the diets that we can do. This is just a repeat of the same information. There's different diets. I want you guys to understand that when we make an alteration to their diet, so if we make it, if they had a regular diet before, but then they had a stroke, so maybe we're going to make them have a puree diet or a ground diet or a soft diet. We are making this diet, we're changing this diet for them so that it makes it easier for them to chew and swallow, because if they can chew it and swallow it and eat it and get that good nutrition in, then they're going to be able to heal and get better. So we want to do whatever we can to get them to be able to eat. So therapeutic diets are different than a regular diet. We use these for preventing or treating a disease or illness. Ultimately, we always want to prevent. But if we don't prevent, then we have to treat. So if you have a patient that is on a cardiac or that has cardiac or vascular disease, we're going to tell our patients to avoid trans fats, right? Trans fats are bad. They're going to avoid saturated fats, and we're going to have them avoid those hydrogenated fats. All those fats are bad. You guys need to know that, okay? And then nutritional supplements. Some patients are unwilling or unable to eat enough food to be able to meet their requirements. So sometimes you can recognize this, you'll be the one who's seeing your patient eat. So if you have a patient that only ate 10 or 20% of their breakfast, and then you gave them their lunch and they only had a bite or two, you can ask for a nutritional consult or ask the doctor to add on like some Ensure. A lot of patients like those. They seem to like the chocolate ones and the vanilla ones. You can put them over, fill a cup up with ice, and a lot of patients like it. They say it tastes like a milkshake. So those Ensures have a lot of nutrients in them. They're not as great as a meal, but they are a nice added bonus to helping them get their nutritional intake for the day. So what kind of fats did I tell you guys that you wanted to avoid if your patient had cardio or vascular disease?
Saturated
Trans
fats.
saturated fats. Trans fats.
Saturated fat.
Yep, you guys need to know those, okay? So here's those nutritional supplements that I was just talking about. Some of them come in clear for your patients who are on a clear liquid diet. The Ensure is like a milk-based drink. They have some that are just for diabetics that have low sugar in them. Some that don't have lactose if patients are lactose intolerant. Some they can actually prepare in pharmacy and send up. And then they have different specially prepared foods. One of the things I see all the time where I work is something called a magic cup. It tastes like ice cream, but it's filled with protein and all the good nutritional stuff that they need. But the patients think it's ice cream and they want to eat it. So you can order that and have that added to their tray every day with that Ensure. So what is enteral nutrition? This is what we're going to be doing this weekend in lab. So enteral nutrition involves passing a tube into the GI tract so that we can administer a formula that contains adequate nutrients. Not everybody that gets enteral nutrition gets the same formula. Some of it is made of a combination of things in pharmacy. Some of it comes pre-packaged. And like I said, if they have high blood sugar, there's a special one. It depends on what they're actually lacking. Some of them cause a lot of diarrhea, so you have to kind of work with them to find one that doesn't cause diarrhea. So there's a lot of different formulas. It is a way of providing nutrition for patients who are unable to consume those adequate nutritional needs through oral intake. They do need to have a functioning GI tract that is accessible and safe to use. Enteral nutrition may augment an oral diet or be the sole source of nutrition. So you will see patients who, a good example of these patients are patients that have cancer. So patients that have cancer of the throat or of the mouth, they will go through chemo, but they also have to go through radiation. So radiation in this area of the throat or anywhere in the face causes a lot of redness on the area, but it's very, very damaging to the inside, to the mucosa in the mouth and the lining of the throat. And they start to develop, their throat swells. So it's hard for them to consume food. It's hard for them to talk. They get sores inside their mouth from the chemo and the radiation. And because of the radiation, they have a lot of thick mucus. All they do is cough and gag on thick mucus. It's really terrible. So you'll see these patients will have enteral nutrition that's augmented. So they will have a clear liquid diet, maybe even a full liquid diet, but then they also have that PEG tube so that they can get the nutrition if they can't take it in. And then some patients don't take anything by mouth and it's their sole source of nutrition. So it just depends on your patient's need. The nasogastric tube, which we talked about a couple of slides back, is the one that goes through the nose and it goes into the stomach. A nasointestinal tube is passed through the nose and into the upper portion of the small intestine. I've never inserted one of those, and I've never seen that done in my hospital. I'm not sure what facility would do that, but it's not something that I've seen. Then we have total parenteral nutrition. We call this TPN. So that's another one of those nursing words. You would never say total parenteral nutrition in the nursing world. You would just say TPN and anybody would know what you're talking about. TPN is a very highly concentrated hypertonic nutrient solution that we can only administer through a central venous access or peripherally. So you would have a central line in your chest. You could also do it by port, and you could also do it peripherally through your vein. PPN, which is peripheral parenteral nutrition, is less concentrated than the TPN, and it is administered through a peripheral vein. So TPN, PPN. PPN is easy to remember because it's peripheral and you just think peripheral nutrition. So who are our candidates for enteral tube feeding? So these are patients who have problems chewing and swallowing, patients who are at a prolonged risk of not having access to food or don't have a lack of appetite or have a lack of appetite, patients who have obstructions, fistulas, altered motility in the upper GI tract. Sometimes you'll see alcoholics, they will get pancreatitis a lot. And the only way to heal pancreatitis is to have bowel rest, which means that they can't have any food by mouth. So sometimes you will see that they will get a G-tube or they'll get PPN or TPN for a small period of time until the pancreatitis heals. So if you have patients who are in a coma, they're going to get that tube feeding, and then patients who require a very high nutrient concentration in their diet each day. So enteral nutrition is contraindicated when patients don't have a functioning GI tract. It's also patients who receive enteral nutrition experience less septic morbidity and fewer infections and complications than patients who receive parenteral nutrition. Why do you think that patients who get parenteral nutrition are at a higher risk of getting septic or getting infection? So what is parenteral nutrition? Again, let's go back. What did we say parenteral nutrition was?
It goes right to the bloodstream, right?
Yes. So it's going to be through that IV, or it's going to be through that central line. So anything that goes into your veins runs the risk of infection. Through any, it could just be contaminated. We could have poor sterile technique when we're flushing their lines. We might not put the cap on the end of it. The patient could do something, so they're at a higher risk of infection. But depending on what their needs are, the benefits might outweigh the risk, and that's the way we have to go. It's significantly less costly than the parenteral nutrition, and then it has not been proven to reduce the length of hospital stays and improve mortality. We can educate our patients how to do this. I educate the patients and their family members and their loved ones all the time how to do this. It's very easy to do, but education is important, especially if they're going to go home with it. So let's see. So factors that influence how and what we use to feed patients. So I told you not every patient gets the same type of nutrition. So we're going to look at what our patients' caloric and protein requirements are, because each formula that we use has a different caloric intake and different protein intake. We are going to look at their ability to be able to digest nutrients. We're going to look at the route that we're doing it. We're going to look at the characteristics of the formula. We're going to look at the equipment that's available. So with that, we're thinking, does a patient, some medications maybe they don't come in a can. Some patients will get can and they'll do bolus feeds where they just put the tube into put like a cylinder into the patient's tube, and then you'll pour it right in there from the can. Some formulas come in big containers and that they have to be on a pump, depending on how much they're getting, if they're getting bolus feeds or if they're supposed to get 30 or 40 cc's an hour. It just depends on what's ordered for the patient and what equipment's available. And then, of course, the method of delivery, how we're doing it. Is it going to go by the hour? Is it just going to go overnight when they sleep? Sometimes that's what you see. We'll hook them up at 8 o'clock to a feeding pump and it'll run till 6 o'clock in the morning. Sometimes it runs 24 hours a day if it's in a central line. And then some patients just get boluses 3 or 4 times a day. Just depends. It's all different based upon your patient's needs. So the feeding route depends on the patient's medical status and then the anticipated length of stay that the tube feeding is going to be used for. The nasogastric tube, like I said, is the most common. And when do we want to use this? If we think they're going to need it for how long?
Less than 4 days?
Less than 4 weeks.
4 weeks.
4 days. Oh, 4 weeks.
Yep, you got it. 4 weeks. This is what we want to use. Doesn't mean we won't use it in 6, but normally that's what we think. If they're going to need it, if they won't need it any more than 4 weeks, then this is probably what we're going to do. If we think it's going to be longer, then we're going to think of something more permanent. And generally used for tube feedings of relatively short duration. So this is just a picture of the different tube feeds. These are the ones that we put into the nose, that we insert into the nose and put into the stomach. They all look different. This is just a general idea of what they look like. Wherever you work is going to determine what type you use, and they all are pretty much the same. They might look a little different depending on the manufacturer, but they're pretty much the same. So the feeding route, so ostomy feedings are preferred for long or short-term feedings, for permanent or long-term feedings. So that means that they're going to have that G tube or that J tube in their abdomen. A PEG tube is placed, we call it a percutaneous endoscopic gastrostomy. Again, not a word that you would say over and over in the nursing world. You would say PEG tube. Everybody knows what you're talking about as soon as you say PEG tube. They use these tubes, they use an endoscope to place these tubes. An enterostomal tube is placed through the opening created in the stomach, which we also call a gastrostomy, or the jejunum, which is the jejunostomy. You can use a lot of different enteral products, many different formulas, depending on what your patient needs. There's a lot of them out there. And they are designed, obviously, to provide complete nutrition for your patient. So you need to know what type of nutrition they need. What are they lacking? What are we trying to replace? So this is the PEG tube that is inserted into the jejunum. So here is the stomach. This little white piece right here is going to be on the outside of the stomach. This is what we're going to see, and it's going to go all the way through the stomach, and it's going to drop into the jejunum. The end of the catheter is where the food is going to be delivered. So when I told you earlier that sometimes I will listen to make sure that that tube is placed, I will push some air into the end of this piece right here with my tube, and then I'll listen for that swish. I'm not going to be able to listen in the stomach because I'm not going to hear it there because it's not there. My stethoscope would have to be a lot further down, probably in that left lower quadrant area, in order for me to hear that. So you have to think about where the placement is of your tube so that you can try and figure out where you're going to listen for certain sounds. So this is just another example of the PEG tube, how they put it in, how it goes through the stomach, and it sits right there. And then they have this little crossbar that keeps it from coming back up. And then you have this external crossbar. And underneath here is where you would put that split gauze in between the top layer of the skin and that crossbar to keep any oozing or drainage. And then you would have a clamp there to stop any fluid from coming out, because when your patients, when that clamp is open, of course you can put anything in. Well, anything can also come out. So if they, sometimes you'll be giving them maybe they're getting a bolus feed and you have your tube in there and you're giving them their fluid and they start to cough. Well, when they start to cough, it all starts to come back up and it can overflow. They can cough, things can come spraying out. If there's any kind of blockage, stuff can spray out. You're not even really a nurse or an LPN if you haven't been sprayed by stomach contents, just saying. It will probably happen. It happened to me. So let's see what else. This is just another picture. So this is a different kind of a tube. They're all different. I've never actually seen one that looks like this on the outside. I've only ever seen the other ones, but these are similar to the catheter. So this is what, when we put in a Foley catheter and it's in the bladder, this is what, when we instill that liquid, this is what blows up on the other end. And this gets seated in the neck of the bladder and keeps the Foley in. And you can do the same thing with this G-tube. So enteral nutrition formulas are based on the amount of protein that they contain. We have standard formulas. We have some that are made from whole protein, some that are made from protein isolates. They provide anywhere from 34 to 43 grams of proteins per liter. I don't need you to memorize that. I just want you to understand that there's a lot of variety in our enteral nutrition, and it's always based on what our patient needs. So we have some that are high in protein, some that are high in calories, some that have fiber to give bulk. So if you have a patient that is not had diarrhea before, and then you start him on this tube feeding and then they start having diarrhea, that's something you're going to want to talk to your doctor about. You're going to want to call the doctor and say, hey, Mrs. Jones, this is day 4 now that she's had her enteral nutrition and now she has diarrhea. She's had 4 bowel movements today. So even though we're giving them that nutrition, if they're having frequent stools or loose stools, are they really gaining anything? Because what we're putting in, they're putting out. So you want to advocate for that patient and tell the doctor so that they can give them another formula that is fiber enriched to help bulk that stool so that they can keep it in. And then we have disease-specific formulas, so patients that have diabetes, patients that have renal failure, and things like that. So we have hydrolyzed protein formulas. So these are where they are completely free of amino acids. They contain only free amino acids, as their primary source of protein. We have partially hydrolyzed formulas, which contain proteins that are already broken down. Some patients that have digestion issues, if they get a lot of abdominal cramps or indigestion, you might have to move to that. It's intended for patients with impaired digestion or absorption. And then we have disease-specific formulas, again, for liver failure, HIV, AIDS, and immune system support. These formulas are very calorie and nutrient dense. Calorie density is a product. The calorie density of a product determines the volume of the formula that's needed. So routine formulas usually provide 1 to 1.2 calories per ml of formula. High calorie formulas, they're going to provide 1.5 to 2 calories per ml. And then your nutrient density, they're going to be very different depending on the formulas, and they range anywhere from 1,000 to 15 mLs per day. There's different water content for all the different formulas. It varies with different caloric concentration. Formulas that provide 1 calorie per ml of formula usually provide 850 mLs of water per liter of formula. Your high calorie formulas are lower at 690 to 720 mLs per liter of water. Adults generally need 30 to 40 mLs per kilogram per day. And then they also need additional free water. So you will see when a patient is on enteral nutrition, it comes with a whole order set will come. It's going to tell you exactly what type of formula they're going to get. It's going to tell you how they're going to get it. So are they getting it bolus? Are they getting it, which when a bolus just means that you're giving it spaced throughout the day. So you might give a can and a half in the morning, a can and a half at noon, and they'll usually give you a time. So a can and a half at 8 o'clock, a can and a half at 12 o'clock, a can and a half at 4 o'clock, and then 2 cans at 4 o'clock. That's considered a bolus. You're just giving the whole thing at one time spaced throughout the day. Or you're going to put them on a pump. And like I said, you're going to do from 8 till 6 in the morning, or maybe you're just going to do, when we're first starting them out, we start them out at 10 mLs per hour for the first hour, for the first 4 hours. And then every 4 hours, you increase it by 10 mLs until they get to their goal rate. And in that order set, it's going to tell you what their goal rate is. For some people, it's 30, some people it's 70, some people it's 45. The nutritionist will decide that. And then it'll tell you in there how often you're checking residuals. So you're going to want to hook your tube up to the patient, and you're going to want to pull back and check every 4 hours, or whatever the lab, whatever the order says, to make sure that they don't have more than, the number usually is 250 cc's or 250 mLs. If you pull back and you're getting 250 mLs, then you're going to start to think, hey, my patient is not digesting this, this formula. Something's going on. So you would put it back in. Whatever you take out, you always put back in. You'll call the doctor. Maybe you're going to hold their next feeding to see if they give them some more time to be able to digest that. And then maybe you need to slow down on your boluses. Maybe you need to cut back on your goal rate. It's kind of like trial and error. But then you also want to give them free water. And then the nutritionist, again, will also decide this. So they'll tell you, give a 240 ml flush every 4 hours, or give 120 ml flush after each feeding. You just have to make sure you're paying attention to your order set and following what the nutritionist orders. The term fiber, so I want you guys, sometimes you'll hear nutritionists say residue, sometimes you'll hear them say fiber. They are used interchangeably. They both mean the same. What is the purpose of fiber? Well, fiber stimulates peristalsis. It increases at the stool, our bulk of our stool, and it is degraded by gastrointestinal bacteria. It combines with undigested food, those intestinal secretions, and the other cells to help make residue. Helps people have a bowel movement. We want to look at osmolality. So it's this is determined by the concentration of the sugars, the amino acids, and the electrolytes. Isotonic formulas have approximately the same osmolality as blood. And then some patients develop diarrhea when a hypertonic formula is infused. So again, this is going to be the nurse. You're going to be the first one there, seeing what's going on with them and being able to advocate for them and talk to the nutritionist or the doctor and say, hey, Mrs. Jones is starting to have a lot of diarrhea. We probably need to switch to another formula that would be better for her. So what equipment are we going to be using? Well, we might be using a pump. It's called a kangaroo pump. Those are the only ones I've ever seen, and I've seen them in all facilities. So I feel like that's probably just a pretty popular brand. I'm sure there's other facilities that don't use a kangaroo, but that's what I use in my hospital. We're going to use different size tubings for the different viscosity of the formula that we're putting in. Our high fiber formulas have a higher viscosity and require a bigger bore, so an 8 French or greater, because if not, it's just going to get clogged in there. Those hydrolyzed formulas have a very low viscosity, so you could use a smaller tubing for that. delivery method. So we kind of talked about this. So this is an important slide. Formulas we can give intermittently, continuously over a period of different hours. The type of delivery method depends on the type of the formula, the type of feeding tube, what we have on hand, and the patient's tolerance. So if you have a patient that you are starting tube feeds on, it's their first time getting it. They've been getting it for about 3 hours now. They call out and they say, something's wrong. I feel really nauseated. My stomach hurts. I'm having a lot of cramping. I'm really uncomfortable. What are you guys going to do? What do you think we're going to do?
Pause it, maybe talk to the doctor.
Yeah, you might pause it. If you don't pause it, you might decrease the administration rate. Okay, so maybe if you, and this is like that nurse-driven protocol where I told you certain things nurses can do without having to ask the doctor. So maybe your patient started out at 10 and it's 16 or 18 hours later, and now we're up to 30. Okay, we increased that every 4 hours, we're up to 30. Well, maybe 30 is too much. So we have the right to just go in and say, you know what, we're gonna check the residual first, see what's in there, and then you can decrease that administration rate, take it back down to 20, take it back down to 10, and then contact the, but you don't wanna leave them hooked up to it while you're talking to the doctor. You wanna make sure you decrease it to a rate that they're gonna be comfortable at. So those intermittent feedings, we talked about that, administered throughout the day, generally used for those non-critical patients, patients that do it at home usually, or they're going to go home with these tube feedings, patients that are in rehabilitation or long-term care facilities. These do more, they resemble a normal food intake. You know, you're eating at those interval times where most patients eat, breakfast, lunch, dinner, and a snack. They allow the client to have freedom between their feedings. They're not hooked up to anything. They don't have to worry about staying home. They can go out for the day with their family because they don't have to carry this big pump. They can just bring their cans with them. It's very convenient. Gastric residuals are checked before each feeding. Why do you think we want to check their gastric residuals before we feed them?
Well, first to make sure that what you gave them before is already gone, processed or absorbed before
Yes.
you stuff more in there.
Yes, very good. That's exactly why we want to check, because if they're not tolerating it, we don't want to give them more. Then they're going to throw up, or they're going to be nauseated, or they could have diarrhea. They're going to have really bad cramps. They're going to be really uncomfortable. So every hospital has a different policy. In general, we say residual volumes of 200. In my facility, it's 250. On more than 2 successive assessments suggest poor tolerance. So if you feed them and then you go back, however your order set says, how often you're assessing that residual. If it's every 4 hours, if you go in after 4 hours and there's 250 or 200 in there, you're going to push it back in, wait another 2 hours, let the doctor know, write him a nice little note, just letting him know this is what I'm doing. I'll touch base with you in another 2 hours. And then go back in 2 hours, check that residual. If that 200 or more is still there, then that's telling us that they definitely are having a poor tolerance. So we need to change the formula or scale back what we're doing. That decision would come from the nutritionist at that point. That's not usually a decision that we make. Those bolus feedings, those are, you know, where we just give a can or a can and a half at a time. This is a variation of an intermittent feeding. We're giving a large volume of formula at a relatively quick rate. This can often cause dumping syndrome. Does anybody know what dumping syndrome is? It's okay if you don't.
Yes.
What is dumping syndrome?
It's when you eat and then you're like, if I think that this is right, if you eat and then you have to like run to the bathroom.
Yes. So yes, very good. That's exactly what happens. So we give them the tube, we give them the feeding, however we're giving it, bolus or through the tube. It's very prevalent with formulas that have a lot of sugar in it. It moves through your stomach so fast and into your small intestine. It goes too fast, too quickly. And then the patients have abdominal pains, they get cramping, diarrhea. It usually occurs within 10 to 30 minutes after eating. So then you have to look at getting back in touch with the doctor, changing how you administer the drugs, how you administer the nutrition. Maybe you're going to change formulas. Again, that will come from the doctor. So then we have that continuous drip method that would be on the Kangaroo pump. We're giving it at a consistent rate over a 12 or a 24-hour period. It is recommended for patients who are critically ill. They're not really getting out of bed. It's convenient. Continuous feedings should be interrupted every 24 hours. I do see patients that do get fluids, do get these nutrition sometimes every 24 hours, but every 24 hours, you're going to take down the pump, you're going to break down the pump, take all the tubing and the food off, and you're going to change it out, because that's like with the IV tubing, it's only good for 24 hours. So that's what they mean by disruption or interruption. Cyclic feeding, so this is a variation of a continuous drip where you give so much through the first 6 hours, and then they want you to get another certain ml over the remaining 4 hours. And then they are usually well tolerated for the patient, because you're breaking up how much you give them. So initiating and advancing the feeding. So before initiating a feeding, the tube placement is going to be verified, right, by getting that x-ray. If your patient has a G-tube, they're going to come back already and they're going to have an x-ray. They are going to put that tube in, they're going to send them off to x-ray, bring them back to, usually this happens in a place called interventional radiology, we call it IR. They're going to leave, go get that x-ray, come back to IR, then the nurse will call you, give report, they're going to come back to your floor. They will already have that it's okay to use order in the computer, and that x-ray will be there. Bowel sounds are confirmed to be present. Regardless of the access route, tube feeding formulas are initiated at full strength. They're usually not diluted. Initial feedings may begin at 10 to 40 mLs. I've only ever seen it done at 10. I think one time I saw a patient start at 20, but this was a patient who had already had tube feedings in the past, and they hadn't had them for a couple months, and they were restarting. So they restarted at a little higher. And then you advance 10 to 20 mLs every hour, or every 4 hours, it depends on what the nutritionist says, until their goal rate is achieved. And this will all be in your order set. So usually what happens when you're getting report from a patient and the previous nurse has already started this, or they've had this throughout their course of treatment, most nurses will say, I mean, I do when I give report, I tell them exactly what the order set says. This is what they're getting. This is how often they're getting it. This is their goal rate. I've advanced them to this. This is what his residuals were. But you always, always, always go in and check that order for yourself, because people can give the wrong information, especially if they got the wrong information from the previous shift and then you just went off of that, because you are ultimately responsible for what you give and what you do to your patient, regardless of what you're told in report. So always make sure you are looking at your orders. Initiating and advancing the feeding. So commonly recommended flow rates for gastric feedings is 125 mLs per hour. Using a standard feeding progression will help to ensure a timely progression of feedings so that you can meet that goal rate. Some tolerance, patients can have an issue with tolerance if they are already malnourished, because their body does not react well to all of a sudden having nutrition, because it's been sustaining with less nutrition. If the body is under severe stress. So not just the stress that you and I get from nursing school or working, this is stress from the body being sick. So if they have any kind of if they've had a major surgery or they are septic or something like that, the body's considered under stress. And then for your patients that have not eaten for a long period of time, you just have to be careful, because once you introduce this nutrition, they can have trouble tolerating it. So what are some tube feeding complications that we can have? Well, we can have GI issues. We can have metabolic and respiratory complications. So aspiration is the most serious potential complication. So this happens if the, say for an example, we have that nasogastric tube that has moved and now it's not in the stomach anymore. Now it's up and it's in the lungs and we're instilling that fluid and it's filling up in the lungs. And they're going to have aspiration. You see these complications are more common with large volume aspirations. And it is a series of clinically silent small aspirations. So with silent aspirations, that can be where your patients are not coughing at all. This increases the risk of aspiration-related pneumonia because that fluid's going to sit in there. Any kind of fluid in a warm, dark area is the perfect breeding ground for bacteria, which can turn into pneumonia. Sometimes if you are, let's see, if you are instilling formula at a very fast rate of speed and the formula is too cold, if it's not just room temperature, this can cause diarrhea, and it can also cause bacterial contamination. So this would leave your patient at risk for developing an infection. You said aspiration, yep, and then we talked about pneumonia. So the goal for most people is that you want to transition to an oral diet. Sometimes that's never a goal for some people. They always just stay with this enteral nutrition for the rest of their life. That's the only option. For the majority of people, we want to transition them to an oral diet. A goal of diet intervention is to ensure an adequate nutritional intake while promoting an oral diet. And then we want to gradually increase their meal frequency until 6 small oral feedings a day are accepted. So what will happen is we will start to scale back on that enteral nutrition, and we're going to start very slowly introducing those meals. And each day or every couple of days, we're going to continue that process. We're going to pull back on that liquid formula, and we're going to keep increasing their oral regular diet until till they're completely tolerating those oral feedings, and then they no longer need that nutrition anymore. All right, so you guys don't have this question. I had a question on mine. I don't know why these slides are missing from yours. So we said earlier that the basal metabolic rate, certain things increase the basal metabolic rate. Does aging increase the basal metabolic rate?
No. Decreases it.
Good. What about fever?
Yes.
Increases the
Yes, increase.
What about growth?
Increase.
Increase.
What about infection?
Increase.
Very good. All right, so we are done nutrition. Do you guys want to take a break?
Yes,
Yeah,
I
before
do.
we take a break, I had a question. Where could we classify the coffee? Is it a full liquid or clear liquid?
So coffee is clear liquid, but
Okay.
no creamer. It has to be black.
Okay, all right.
Okay.
Can I ask a question about the bolus feedings? Because you said it can cause diarrhea in patients or like dumping syndrome. So
Yes.
in what case would you, I don't know if you said it, but because I was typing, in what case would you prefer that over a regular feeding, like all at one time like that?
Say it one more time. When would I prefer
Why
what?
would you, because it's all at once, the bolus feedings. So why would you give that to a patient over just a regular amount instead of
So-
large amounts at one time?
So I'm still a little confused. So why would we give the bolus feeding?
Yeah, just all of that at one time because it's a large volume of
So why would we? So
at
because-
once, right?
Right. So it's just a can and a half. So it's like this. I mean, that's like a can and a half of soda. So we can tolerate it for one. And for two, it's convenient and it resembles more of a normal like oral diet, how we eat. So we eat in the morning and then we eat at lunch and then we eat at dinner and then it's very convenient. So they're not hooked up to a pump and they're not getting that continuous feeding, but they have to be able to tolerate the bolus feeds. This is more of a patient who's had one for a while and it's more established. They don't need that pump anymore. They can have it spaced throughout the day and they're very independent with their care.
Okay, got
So,
it.
yeah, dumping syndrome, that could just be from the formula. It doesn't mean that they can't ever have bolus feeds. Maybe we need to change the formula, or maybe their body just has to work up to that bolus feed. You might see that in someone who has a new G tube or a J tube.
Okay, got it. Thank you.
Yep. All right, guys, you want to take a 10-minute break?
Yes, please.
Okay,
Yes.
10
Ms.
minutes.
Davis, I had a question about while we on the break. You said you post the exam for Tuesday? Our next exam is Tuesday?
No, for Thursday. Did I say Tuesday?
Oh, I thought you said Tuesday. I was scared. I was freaking out.
No, I posted your exam to download today for Thursday.
Okay. So remember we had exam due on the 2nd though. That got pushed back, right?
You don't have an exam due on the 2nd. Wait a minute. Yes, you do. Exam 2 is, yes, you do have exam 2 for.
Yeah,
this-
but I thought we pushed that. I thought we pushed it back.
No. We never made any changes to this class. The only class we made changes to was pharmacology. And
Pharmacology got pushed back.
we pushed your dosage back. I added another exam and then your dosage should have been last week, but I gave you another week and made it be this week instead of last week.
So we do have one in this class for the 2nd.
Uh-huh. Yeah. Yeah, so
The Christ of Nazareth.
tonight is the last night. This is the last bit of information for exam 2. We're going to do aging 2 next
After the
Tuesday
exam.
after your exam. And that's on your,
Also, Asian one is going to be on this.
yes.
Okay, thank you.
Okay.
What was the question? You said aging going to be on this?
Aging 1 is going to be on this test. Aging 2 is going to be on the next exam.
Oh my God.
So aging part 1. So this is the last lecture for your exam material for next week's exam. Aging has 2 parts. Part 2 will be on your 3rd exam and we will start that next week after your exam. So what are our learning objectives for aging? We want to be able to summarize the theories that describe how and why aging occurs. We want to describe major physiologic, cognitive, psychosocial, moral, and spiritual developments and tasks of middle and older adulthood. We want to describe common health problems of middle and older adults. We want to describe physiologic and functional changes that occur with aging. And we want to describe common myths and stereotypes that perpetuate ageism. So, all right, we have 3 definitions here. So we will see who did their homework before coming, if any of you guys have looked at your information, and we want to see if we can fill in the blank. So blank is the science, I'll even give you the 3. So the 3 topics that we have. One is gerontology, one is geriatrics, and the other one is gerontologic nursing. So what is the scientific study of the aging process, which focuses on determining answers about normal aging process? What do you guys think?
Gerontology.
Gerontology.
Gerontology, you got it. Very good. Blank is the medical specialty dealing with diagnosis and treatment of diseases affecting the elderly.
Geriatric.
Okay, some people say geriatrics. Let's go down. And did someone say gerontologic nursing? No, okay. You're right, it's geriatrics. And then obviously the last one is gerontologic nursing. And that, is gerontologic nursing, that applies the nursing process to older adults so that we can achieve a level of wellness that's consistent with the limitations opposed by aging. So we have a couple different theories of aging. So we're going to try and match this up. So let's see. For genetic, which one of these, A, B, C, or D, do you think is the genetic theory of aging? So we have a chemical reaction that produces damage to the DNA and cell death. We have B, which focuses on the functions of the immune system. C is genes control the genetic clocks. Or D, modules with separated high energy electrons have adverse effects on adjacent molecules.
C. Is it C?
Yes.
C.
Yep, so genetics. So just think gene and gene. So the genetic theory of aging believes that genes control everything and that there's a genetic clock. So then we have immunity. Which one do you think is immunity?
B.
B.
Yes, very good. So the immunity theory of aging is focusing on the functions of the immune system. Then we have cross-linkage. What do you think that is?
D.
B.
A.
Ooh, all kinds. How
D.
many?
A.
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 D.
It's A.
A.
Yeah, cross-linkage is a chemical reaction that produces damage to the DNA and ultimately causes cell death. So then free radical is the only one that is left. So the free radical theory is based on oxidative stress. Free radicals, these are usually formed during cellular metabolism, and they're molecules with very high energy electrons that seek to combine with other molecules. When the electronic pairing occurs, when those electrons pair up and get together, it disrupts cell membranes and it affects DNA and protein synthesis. So a lot of people believe that this is how we age through the free radical theory. So which theory of aging focuses primarily on metabolism and function?
D.
D, you got it. Very good. The free radical theory. So the development of the middle adult. So we have all kinds of changes: physiologic, cognitive, psychosocial. For physiologic, so the middle adult years are usually between the ages of 40 and 65. What we're seeing now is that the average lifespan has increased. So most of the people that are in this middle age group consider themselves young compared to the older population, because now our older population is 90s, 80s. So yeah, for 50, we feel young. Visible signs of aging are starting, and people in this age group start to become aware of the time that they have left. They can look back on how fast their life has gone already, and then they look ahead and say, oh, maybe I only have another 30 years. Makes them evaluate their achievement goals and then their influence to adapting to older age. Physical functions are usually relatively still effective in the younger part of the middle adult. As time passes, internal and external physiologic changes will start to occur. These are not pathologic changes, but they're normal changes that result from aging. Patients must modify their self-image and their self-concept to be able to adapt successfully to and accept these normal changes. This is what people have a lot of problems with. So we get more fat deposits, like I said earlier, around our waist. We start to get wrinkles. We get gray hair. For some people, you might have a loss of hair or a thinning of hair. Especially for women, when you go through menopause, you're losing that calcium, and you're going to start having visual acuities. Your vision's going to decrease, your hearing might change a little bit, and your cardiac output is going to decrease. These are all normal age-related changes. It's not a pathologic change. I want you guys to understand that. And then, of course, we're also going to have an increase in fatigue. So cognitively, there's very little change from a young adulthood to middle adulthood. We see that usually there's an increased motivation to learn because we're starting to look at, hey, I don't have this many years left, and this is still what I want to, there's things I want to accomplish or things that I want to do. So the motivation is there to do things now, especially if whatever we're trying to learn can be applied immediately and it has like a personal relevance. Problem-solving abilities remain good throughout adulthood. Response time does start to become slightly longer. And this is not due to any decreased ability, but rather it takes longer to search through more memories and to a desire to think about a problem before we respond. And then our psychosocial. So it is a time of increased personal freedom, economic stability, and social relationships. So if you've raised children and you've done everything for your children and you had to live a certain lifestyle, well, maybe when you get to your middle adulthood, your children are growing up and it's time for you to do things that you wanted to do. The middle adult starts to realize that his life or her life may be half or more past, and they have feelings that things are still undone. So this can sometimes cause what you guys have probably heard, a midlife crisis, and it can also cause situational stressors in the life. So which example is a developmental task of the middle adult? A, continue an established lifestyle or reorganize one's life in a period of transition. B, adapt to and face already completed tasks. C, choose a vocation, which would be a new type of a job, or learn something new. And then D, develop an ethical system as a guide to behavior.
B.
Ms. A.
How many people say B? How many people say A?
I say A.
Only one person said A. I need more people to talk. A or B? Okay. The answer is A. Yes. So that is the developmental task of a middle adult. You're going to continue on that established lifestyle that you have, or you're going to reorganize your life because you're in a period of transition. So developmental tasks of the middle adult. We accept and adjust to physical changes, and we maintain a satisfactory occupation. We assist our children to become responsible adults. We are also adjusting to aging parents. And then we have what we call a caregiver role strain. So this is something that I'm actually can relate to because my youngest child is 17. My oldest child is 30. I'm helping to raise grandchildren. I'm helping them out. But then my in-laws are also in their mid to late 70s, almost 80s, and their health is starting to decline. And my father-in-law had a stroke over the fall. And we were back and forth. It seemed like every weekend trying to help him recover. So it's kind of hard. You're caring for your aging parents, but then you also have kids of your own that you're trying to help. So that's what that caregiver role strain. And then we can relate to one spouse or partner as a person. So this is called Havighurst's theory. This is what he believes, and this is in your book. You can look this up. So what are the excuse me, what are the leading causes of death in middle adulthood? Strokes, cerebrovascular causes, cancers, cardiovascular disease, unintentional injuries, diabetes, and then chronic lower respiratory diseases. So what would be a cause, what would cause someone in their middle age, in this middle age group to have chronic lower respiratory disease? What do you think? What kind of life?
Smoking.
Very good. Smoking, environmental issues. So if, depending on where they work, what about diabetes? What is going to cause diabetes in this middle age group?
Lifestyle.
You got it. How about unintentional injury? What kind of things are we thinking?
Shoveling the snow.
Accidental.
We said the same thing.
Is it car accidental?
Yes. So car accidents, shoveling the snow. You hear this all the time about the 40-year-old guy who lives down the street who shoveled the snow and he had a heart attack the next day because he had cardiovascular disease. Yeah.
I work in the clinic. We had 20 people come in today who fell on the snow. 20.
Wow. 20. Yep. Yeah. They fall, they hit their head, they bleed out. Yep. It happens. That's terrible. All right. So cardiovascular disease. What do you think is causing cardiovascular disease in these middle-aged people?
High cholesterol.
What's caused? Yes. Very good.
McDonald's.
High cholesterol. McDonald's.
Fast food, yeah.
Yes. Poor diet, no exercise, sedentary lifestyles. So these cancers, so things that I want you guys to think about for cancer. So as you get into these middle ages, there's certain things that you should be recommending that your patients have. So you're at age 40, you should be having a mammogram every year. A colonoscopy when you turn 50. If you are maybe closer to that 65 mark, which is just at the end of the middle adult, then you will be going for bone scans to check for osteoporosis and stuff like that. So what do you think is causing these cerebrovascular causes, these strokes?
High blood pressure.
Yep, high blood pressure. What's causing the high blood pressure?
Smoking.
Over obesity, maybe?
Yes. Yes. So
Diet.
yes. That we've been talking about. So the patient down here that has diabetes because his appetite is poor, he's sedentary, he's not working out. He probably isn't monitoring his blood pressure either. Smoking cigarettes, working night shift, crazy hours, working a lot of hours at work, cardiovascular disease. So these all have an effect. And then the cancer too, you can link that down here to the smoking the cigarettes. Okay.
High sodium intake.
What's that?
Oh, I said high sodium intake.
Yes, high sodium intake, poor diet. Yep. All right. So what is the role of the nurse in promoting health? We're going to educate our patients about the dangers of substance abuse, about smoking cigarettes and consuming less alcohol. We're going to encourage adults to eat a diet that's low in fat and cholesterol, high in protein, lots of veggies, lots of fruits. Stress the importance of regular exercise. What do I mean by regular exercise? Well, we want you to work out 3 times a week, at least 30 to 45 minutes a day at the minimum. We want to talk about caregiver role strain, which would be related to role commitments, trying to manage those teenagers and take care of your ailing, older parents. A nursing diagnosis would be risk for ineffective relationship related to unrealistic expectations or readiness for enhanced family process. So this takes a toll on families. It takes a toll on you getting older, dealing with all these things, especially the psychosocial component of it. So there's a lot of different diagnoses that you can apply. So age demographics, the older adult is often divided into, so what we have is young adults, 60 to 74, and then middle old, and middle old is 75 to 84. And then we have the old. I love that, old. That's like really old, age 85 years and older. And the closer you get to that old, it seems younger. It doesn't seem as old. Like 50 doesn't really seem old to me now because I'm 50, but when I was 20, I thought it was ancient. But the closer you get to it, the more acceptable it seems. So society has labeled the older adult as a person older than 65 years of age. That's really young. You still have a lot of life left in you. You're still very productive, working. Even nurses, I work with a nurse who's 72 and she doesn't have any plans of retiring until she's like 78, she said. And she's healthy and she takes care of herself and she probably will be able to do it. So the life expectancy in 1970 was 70 years old, 70.8 years. Today, it is 77.7. So we can see in the last 50 years how the life expectancy has increased. What do you think contributes to that life expectancy increasing? What's happened?
You don't have like a lot of the diseases that
Technology.
Technology advancement.
Advanced medicine.
Yep, advanced medicine. That's your answer right there. Advanced medicine. Yep. Because we do have access, we know more, we can educate our patients more. We are doing more of a preventative role in the communities with trying to prevent these things, but we have more tools to be able to keep people alive longer. We're giving them medications. We're just, keeping them alive by giving them medications for every ailment that they have. So, the development of the older adult. So physiologically, all organs, so now this is the older adult, right? We talked about the middle adult, this is the older adult. All organ systems undergo some type of decline in the way that they function overall. The body becomes less efficient. If you look in your book, box 23-3 of this chapter lists all the normal physiologic changes of the older adult. If you want to read more, because there's a lot in there. And you'll notice that the body systems that are affected the most are the ones where the body functions that require that integrated activity of those several organ systems working together. Cognitively, cognition does not change appreciably. Intelligence actually increases up until the age of 60. Learning continues throughout life. So they always have the possibility to continue learning and increasing their knowledge. It is normal for an older adult to take longer to respond and react, particularly in a new or an unfamiliar surrounding. So knowing this as the nurse, you should slow the pace of care and that you're providing to your patient and allow older adults extra time to ask questions or complete activities. This can be a challenge sometimes because we're always trying to improve our time management. Rush, 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 rush. We got to get to the next patient. We have so many tasks to take care of that we're just always rushing as nurses and LPNs. But with the older adult, you really need to take that time and listen to them. Don't answer for them. Don't anticipate what you think they're going to say and then put words in their mouth because you want to hurry them along. If they're going to the bathroom and they're cleaning up, give them that extra time to do that because they do slow down as they get older. Their reaction time changes. You're going to start to see mild short-term, which is memory issues. So your short-term is your recent memory. So what did you eat for lunch today? Who came to visit you yesterday? What book did you read last month? This is common, but it can be remedied. So you can incorporate different things to help them. So you can put them on a schedule. You can create calendars. You can encourage them to put notes around the house, things that will remind them. And then psychosocial, their self-concept is relatively stable throughout their adult life. The older adult who has a strong sense of self-identity and has successfully met challenges earlier in their life will probably continue to do so. So they always say that if you work in hospice, they say that when people die, they usually handle their death like they did their life. So if they're very strong and they were just go, 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 that's probably how they're going to handle their death. It's the same thing with developmentally, how they get older. That's how they handle it, how they were in their younger years. So this is our psychosocial theory. So your disengagement theory, this is where older adults often withdraw from usual roles and become more introspective and self-focused. That's what we call the disengagement theory. The activity theory is successful aging includes the ability to maintain high levels of activity and function. They believe that this is the key to aging gracefully. You should be exercising. You should be doing things that engage your mind, like playing certain games like Sudoku and things like that. Then we have Erikson's theory, which is the ego, integrity versus despair and disgust. So this is where you are doing a life review, you're reminiscing about certain things. And then we have Haviger's theory, which we talked about a couple slides back. So major tasks are maintenance of social contacts and relationships. So you're staying in touch with your family, you're staying in touch with your friends, you're active with them. And then it believes that you should find new and meaningful roles in old age. So the ANA standards of gerontological nursing practice. So this includes the scope of gerontological practice. It is this, they develop the scope of practice. So what we can do as LPNs, what we can do as RNs, they develop the standards of care. What are the minimums? What is the standard of care? What is the basic needs that we have to meet? Every care should include X, Y, and Z. And then professional performance. What are our expectations professionally with taking care of the geriatric population? They develop specific criteria for defining expectations and competent care. And they have created a guide to current practice across all settings when dealing with this population. So myths, stereotypes, and ageism. So sometimes older adults can be victims of ageism. Ageism is a form of prejudice like racism, but in which older adults are stereotyped by characteristics only found in a few members of their group. So some people might say that old people are slow, or old people shouldn't drive anymore because they don't know what the heck they're doing. They should have to turn their driver's license in. They should have to have a driving test every year. Old people shouldn't be allowed to go to the grocery store because they hog up the lane and they take too long. You know, those are the type of stereotype things that we're talking about. Let's see. What else? Different myths. Most older adults live in long-term care facilities. That's the furthest from the truth. Only a small population of our older adults live in long-term care facilities. Through preventative medicine and preventative education, adults are living longer and they're living productive, good quality of life. You can't teach an old dog new tricks. Well, they're old, they're never going to be able to learn that. Well, they might have trouble learning it. It might take them a little bit while to get used to it, especially when we talk about like electronics, computers, TVs, modern technology, but they certainly can get used to it. It just takes a little bit more time. And then the secret to successful aging is to choose your parents wisely. Well, none of us have obviously have a choice in choosing our parents, but some more myths: the elderly are not safe and reliable workers. That's not true at all. Older people are not interested in sex. Well, unfortunately, that's not true. My in-laws joke about that all the time, and I die 1,000 deaths every time my father-in-law says something because I just can't even imagine them having sex because I think they're so old. And then to be old is to be sick. Well, that's just not true. I mean, there are many, many older people that are very healthy. They eat a great diet. They stay active. They're still working. So those are just a few of the myths. So which of the Which of the following of the statements are true regarding older adults and the aging process? So senility is a normal part of aging.
False.
False. Very good. To be sick is to be, to be old is to be sick.
False.
False.
The older you get, the more religious you become.
False.
False.
Most older people have no interest or capacity for sexual relationships.
False.
False.
Do you know where the highest percentage of sexually transmitted diseases is found at?
Nursing
Nursing homes.
Florida.
Yes. Who said Florida? They have like the villages down there, which is like a community of like 75 million middle to older adults. And yes, that is where you find it because they are still very sexually active. It's crazy.
My in-laws live there and we made a lot of jokes.
Oh, did they live in the Isles down there?
In the villages,
In
yeah.
the villages, yes. The Isles, I think, is in Naples. That's funny. Older workers are less productive than younger workers.
False.
False.
Health promotion is wasted on older people.
False.
False. Older people are set in their ways and cannot learn new things.
False.
Older people are more likely to be victims of crime.
True.
True. True,
Ah.
they are.
Yeah. That's
They
true.
are. Yeah. They become very naive and it's very easy to trick them and convince them to do things. So as a nurse, you need to understand that aging is a very natural process. It begins at conception and continues throughout the entire life cycle. You need to assess your own attitude towards aging in your patients, just like all the other things that we deal with. Aging yourself, your family, and friends, because this helps understand and develop positive attitudes towards aging that will be able to help you enjoy your work with elderly people. So the nursing process. Somebody needs to mute their microphone, please. Thank you. So together, the nurse, the older person, and significant others will begin by assessing the patient's strengths, their resources. So who do they have at home to help them? Do they live alone? Do they have a lot of steps in the home? What kind of other chronic diseases do they have? Do you think they're able to cook for themselves? Are they able to wash their laundry, take their trash out? Talk with that case manager, see what kind of resources are available to help them, and then any limitations they have. This is followed by identifying the problems and the needs that are going to impact those activities of daily living, because those are the things that are most important, right? Being able to wash yourself, get dressed, cook for yourself, be able to eat. And then the nurse with the patient will select, plan, implement, and evaluate measures that maintain physical ability and create an environment that is will further both the psychosocial and spiritual well-being. So assessment, normal aging changes. So most commonly encountered chronic disorders are your hypertension, arthritis, heart disease, cancer, diabetes, sinusitis. At least 80% of older adults have at least one chronic disorder, and most have at least two or more. Their ability to adapt determines whether or not they are ill or healthy. Infection control. So in general, we're going to see face wrinkles, gray hair, thinning of the skin. Integumentary, that skin's going to lose the elasticity. It's going to be sagging. It's going to tear very, very easily. You want to be careful with these older people. Sometimes I've seen it happen where you just touch them and you're moving their hand over and the thumb or one of your fingers can just go right through the skin and the skin will come off. They'll start bleeding. Their skin is very, very sensitive. They get dry skin, age spots, decreased sweat glands, and then they have less efficient pooling changes. Decreased skin elasticity and skin thickness can lead to an increased chance of developing pressure sores. So we're going to make sure we're rotating those patients in bed every 2 hours, getting them to the chair, turning them over and putting a pillow under them, elevating those heels. And then due to years of sun exposure, skin malignancy is more common. So when we talk about perfusion, our cardiac output is decreased by 40%. That's a lot. 40% is a lot, almost 50%. Those vessels are going to decrease in elasticity, so they're going to be harder. Your stroke volume is going to decrease. Your peripheral vascular resistance is going to increase. Do you guys know what peripheral vascular resistance is? It's okay if you don't. We're going to talk a lot more about this in homeostasis. So the resistance is in your veins. If this is a vessel, it is the force when the blood is shooting out of your heart and it's going into the veins. The resistance is what it meets when it's going through there. So if you have blockages of cholesterol and things like that, or if your vessels are not flexible anymore and they're very stiff, well, then your resistance is going to increase. Okay, the increase is going to come from when the blood's shooting out of the heart and it's going to meet resistance in that vasculature. So if you have increased resistance, decreased smoke volume, and you have a decreased elasticity in your vessels, your blood pressure is going to go up. That's why we see an increase in blood pressure. And then you're going to see changes in your heart valves. So they may not open and close like they should. They may stay open. They may open when they're not supposed to and close earlier than they should. A variety of different issues. So we talked about what's going to happen in the body. How are we going to see it in our, how are we going to see those changes in our patients? So if that stroke volume is decreased and that vascular resistance is increased, then the blood that's coming out of the heart is not going to be able to get all the way where it should be peripherally. So our peripheral pulses are going to be weak. So our dorsipedalis, our anterior tibial pulse, all those are going to be decreased. Our radial pulse, their feet are going to be cold. Why? Because we don't have that good circulating volume. Venous return becomes less efficient. If we don't get good venous return, what does that mean? So when our heart shoots the blood out, it should be strong enough that it goes all the way around through the entire body, back up to the right side of the heart to be reoxygenated again. If it does not happen, that blood is going to pool in those lower extremities. It's going to be cool, and you're going to get swollen legs. We're going to have that edema. That's because the venous return is not efficient. And then we're going to have orthostatic hypotension. That orthostatic hypotension is when we're going to see a drop in that blood pressure systolically and diastolically when we change positions from laying, sitting, and standing. So those are the normal aging changes we see in perfusion. So what's going to happen inside with our oxygenation? So our pulmonary elasticity and ciliary action are going to decrease. So if our ciliary action decreases, we are not going to be able to filter and clear our lungs of all the stuff that gets in there. That whole process becomes less efficient because now we lose that elasticity. Things aren't moving like they should be. After age 55, respiratory muscle strength decreases. So if you don't have that muscle strength in there to take those deep breaths, you're not going to get in the air that you should. Our vital capacity is going to decrease. Does anybody remember what vital capacity is? You guys should have learned about this in biology. It's okay if you don't know. Somebody want to try?
Is it the vital capacity in the lungs?
It is. It's in the lungs. It's the amount of air that the lungs can expel after being completely filled. So what happens is,
Yeah. Okay.
yeah. you can get more of a barrel chest. And you see this all the time with COPD patients because we fill our lungs with air and then we can't get it all out. So that more of it stays in there. So that's why you get that barrel chest because it's always so filled with air. You're going to have a decreased number of alveoli. So you know those little alveoli, there's those little things that look like broccoli on the end. They all open up. They help get all that air in. You're going to have a decreased number of them. They're not going to work as efficiently. You're going to have a decrease in gas exchange. And then you're going to have a decreased cough reflex. So this is why the older population is so at risk for developing pneumonia. It's the perfect storm. You know, they're already in the hospital and they're not moving like they normally would for whatever reason. And then they're older and they have all these normal aging changes that put them at risk for developing pneumonia, and they get it and then they die or they end up in the ICU or they just get really, really sick. It increases their hospital stay. So this is why those nursing interventions that we do are so important. We know all these normal age-related changes. Get your patients out of the bed and into the chair. Walk them in the hallway. Give them an incentive spirometer if they don't have one. Encourage them to take deep breaths and to cough. These are all things that the nurse can do. You don't need an order for these things except for the incentive spirometer. So elimination, what's going on with our elimination pattern? So we have decreased peristalsis. So if we don't have good peristalsis in our GI tract, we're going to have constipation and we're going to have indigestion. Our digestive enzymes decrease. We don't have as many of them. So if we don't have as many digestive enzymes, we're going to have indigestion. We're not going to be able to digest our food properly. We have less of a gag reflex. If we have less of a gag reflex, we are at risk for aspiration and choking on our food. A more protuberant abdomen due to the loss of abdominal muscle strength. So when we say a protuberant abdomen, it's just going to be a nice puffy round little belly. And then we're going to have decreased taste sensation, which contributes to what? If they have decreased taste sensation, what other problems are they going to have?
Decreased appetite.
You got it. Decreased appetite, nutritional issues. You guys are starting to see now how this is like the perfect storm for all these older adults. We're going to see gum atrophy. We're going to see decreased saliva production that leads to dry mouth. It's very, very common for these older people to always be dry. Malnutrition and anemia become more common. For men, they're going to have BPH, their prostate is going to enlarge, and the bladder capacity decreases by 50%. That's huge. So if you could normally hold 1,500 mLs in your bladder, you're only going to be able to hold 750. So what do you think is going to happen? You're going to have urinary retention and then stasis. So that's the perfect medium for UTIs. Whenever you keep your urine in there, it's a dark, warm environment. All that infection is just going to take over and your patients can become septic. UTIs. Or they're going to have frequency issues. They're going to have frequency issues. They're going to have urgency issues. They're going to have nocturia where they're getting up and we talked about this a couple of weeks ago. They're getting up in the middle of the night and they're going to the bathroom. So if they have nocturia, urgency, and frequency, what does that put them at risk for?
Falls.
Yes. Yes. Very good, guys. Very good. Fall risk. It's very good that you can put all these pieces together. Critically thinking. You're thinking like nurses. So what happens inside? Our nephrons that help with elimination, we lose them by 50%. We have decreased renal blood flow. Why do we have decreased blood flow to our kidneys?
Dehydration.
Could be dehydration, but what else? Let's go back to what did we say when we talked about perfusion? What happens to our perfusion?
Not sufficient.
Yes. So perfusion, decreased cardiac output, right? Decreased stroke volume, that vascular resistance. We're not getting enough blood out to perfuse the body. It's not perfusing any of our organs either, right? So then in turn, we have a decreased filtration rate and then decreased kidney ability to be able to concentrate the urine. We have decreased muscle tone and then decreased urge and then sphincter control, which means you're going to have dribbling and incontinence issues. So when we talk about mobility, we are going to have a loss of height. This is very often seen in women as they lose estrogen after they hit menopause. It happens rapidly. They can get osteoporosis and they start to lose height up to 2 inches. They can develop kyphosis, which is that big hump in the back. Your bones become more porous and brittle. So this is why we want to prevent falls in older adults, because all of this stuff is, happening, and then they fall and they break a hip. If you and I fell right now, we might not break a hip, but in these older adults, they're going to break anything as soon as they fall. Joint changes, so they're going to have decreased flexibility. Their cartilage is going to degenerate. They're going to have sarcopenia. Sarcopenia is that loss of muscle mass and strength. And then they're going to have a loss of calcium from their bones, which also puts them at risk for bone breakage. So our normal age-related changes for sensory perception. So we're going to have a decreased pupil size. They're going to have a decreased tear production. Older adults always, not everyone, but a lot of times complain about their eyes being very dry. You're going to have a decrease in your lens clarity, being able to discriminate different colors and being able to focus. You're going to have a decreased adjustment to light and dark. You're going to have presbyopia. So presbyopia is the gradual loss of your eye's ability to be able to focus on nearby objects. You're going to have an increased sensitivity to glare and then a decreased ability to adjust to darkness. So you might hear your older patients saying, I have no problem at all driving during the day, but at night, the headlights coming from the cars coming the opposite way completely blind me at night. I have a hard time driving at night. That's something very common that we hear. So if you think all this stuff is going on in their eyes, if you're doing Perla on a patient, what do you think their reaction is going to be if they have all these changes going on? It doesn't mean it will be, but what could it be? We talked about this last Saturday.
Slow.
Yes, what do we call that?
Sluggish.
Sluggish, yes, very good. Not brisk, sluggish. Their hearing is going to be, go south. They're going to have a progressive hearing loss, which usually starts with high frequency tone. Decreased discrimination. They're going to have excessive buildup of wax in their ears and thickened eardrums.
Did you change the slide?
Oh God, I'm sorry. Yes, thank you. Sorry about that. As far as touch, their sense of touch dulls. The ability to distinguish temperature and feel pain also decreases. It doesn't mean that they don't need pain medication, and it doesn't happen with every patient, but some people will say that they have decreased feeling in their feet or their fingers in their peripheral areas. So perception, the taste, the number of your taste buds decreases. So that's going to obviously affect the way you taste food. Sweet and salty tastes diminish first. Their smell, they're going to have a decrease in their olfactory nerve fibers, a diminished sensation to distinguish between specific odors. Reproductively, males, they're going to have thinner pubic hair. They're going to have smaller testes. Their testosterone and their sperm production is going to decrease starting in the 4th decade. So when they are 40 years old, their prostate is going to enlarge, and the ability to initiate and maintain erection and a weaker ejaculation. For females, they're also going to have thinning pubic hairs. Menopause is going to accelerate aging. As soon as they don't have a period for 1 year, things start happening, progressing very quickly. Your ovaries get smaller and sclerotic. Your fallopian tubes and uterine, your uterus atrophies will occur. Your vagina becomes smooth and dry. You have a decreased muscle tone and elasticity, which results in sagging of breasts, and your breast becomes smaller. Neural regulation. So we've talked about some of this stuff. Slowing of thinking and reacting, slower of reaction time, slower reflexes. They're going to have sleep changes. They might wake up in the middle of the night. They might have a hard time falling asleep, or they might go to bed at 8 and wake up at 5 o'clock. Decreased response to heat and cold, decreased cerebral blood flow, decreased sense of balance, and uncoordinated motor movements, fine movement and spatial orientation. That's going to increase these patients for a risk of falls. And then they sleep at night may shorten, and they may awaken more easily.
I must be an older adult because I definitely like to go to sleep at 8 and I'm always up by 5.
Yep, and you'll probably always stay
Okay.
that way. Yep. So for cognition, basic intelligence is maintained. Learning is not seriously altered. It might take a little bit more time, but it's still possible. Their attention span is going to decrease, which means you may have to reorient them frequently, keep them, keep telling them what you're doing and why you're doing it. Their memory starts to slow down. It might not be their attention span. It could be their short-term memory. Sometimes it's a little hard to discern which is which. No drastic personality changes. Usually you see that in patients that have Alzheimer's and dementia. They're the sweetest, kindest little old ladies or old men during the day, and then they're the complete devil when the sun goes down. They're like, it's like, have you ever seen the movie, I can't think, Gremlins, where you add water to them and they multiply and they turn into these angry muffins? Well, this is exactly what people that have dementia and Alzheimer's are like. They're completely different at night. It is a common misconception that cognitive impairments are widespread among older adults. It's just not the case. And older adults do fear that they will no longer be able to handle their own affairs. So this is something really important I want you guys to always think in the back of your mind. So when you're taking care of an older adult and you're asking them questions like, have you had any falls in the last 6 months? They may lie to you, because if they've been in the hospital before and they've already had a fall before, they know what's coming. They know that you're going to get PT and OT involved, and they know that if they are not deemed safe to go home, they have to go to long-term rehab. People would rather stay in their home and fall and not being able to take care of themselves than to go into long-term rehab. So you want to get family involved if you can, if you don't think that they're being honest with you, or you don't think that they are being a good historian. If they have dementia or some kind of short-term memory loss, you really need to advocate for these people. They don't want to lose their independence. They don't want anyone telling them that they can't do X, Y, and Z. They don't want to give up driving. They'll tell you that they're okay driving when really they've crashed their car into a pole 3 weeks in a row. They don't want to be honest. So just keep that in mind when you're dealing with them. And that's it. Getting old is a privilege that is denied to many. I know that a lot of this doesn't seem ideal. The body goes through a lot of changes, but it is a privilege denied to many, so you have to embrace it and appreciate it.
Ms. Davis, can